I request Dr. Ashish Joshi to do a quick address before we begin.
Hi, good evening everyone. Thank you so much. I think Ganesh has already set up the tone for the meeting. We are got few talks and then followed by case discussion to have translated the research into the bedside. Maybe few years back, medical oncology would not have been there as a part of the HCC treatment paradigm. But as has been seen in most of the solid tumors, things have changed dramatically. And I think next couple of hours, we will have academic feast with all the colleagues, friends, teachers here to discuss HCC, MDT and the concepts. So over to Saurabh.
Let's begin with our program. I am announcing the first session on changing trends in epidemiology of HCC. And I invite the first speaker, Dr. Amit Mandot, Senior Consultant Clinical Lead, Adult Hepatology and Liver Transplant from Global Hospital.
Thank you, Ganesh and Ashish. As Ganesh rightly pointed out, HCC is something which is undergone a paradigm change, and as hepatologists, we always feel we should be at the center of the whole management, and the changing epidemiology of HCC tells us that the etiologies have changed, but still it is a cirrhotic patient who is maximum at the risk of HCC, and that is where it is different from other tumors. So just to give you a little background, we all know that the liver cancer, the global incidence and mortality is increasing. Liver cancer today represents 4.7% of all cancer diagnoses, with the sixth most common cancer overall, with it being more common in males than females. And the number of cases have seen a significant increase over the last few years. And it is the third leading cause of global cancer mortality. So it is one of the most important cancers, and it accounts for almost 8.3% of all cancer deaths. So if you go by the numbers, there's just a pie chart which gives you the breakup. The global incidence is almost 8 lakh new cases per year, and almost more than 75% of cases occur in the less developed regions of the world. And that's not surprising, because hepatitis B is one of the major risk factors, the most common risk factor, and it was always common in the less developed regions of the world. And I don't think we have still unearthed the whole epidemic of hepatitis B still. There is still a lot of cases which are undiagnosed, and over the next many years we would probably still be seeing a lot of cases of hepatitis B related, especially in areas in the countries where vaccination is not yet a reality. And yes, with the epidemic of metabolic disease, fatty liver, NASH, it has again increased exponentially. So liver cancer is the 5th and 9th most common cancer in males and females, and men have 3-fold higher risk of developing liver cancer than women. Almost 90% of liver cancers usually would be HCC, and 10% would be other. We would primarily be focusing on HCC here. So almost 90% of tumors in the liver, primary liver cancers, are HCC. And the most significant risk factor for developing HCC is the presence of cirrhosis. So almost 80 to 90% of HCC occurs in the background of cirrhosis. And this is very important. And this is where a patient with HCC would differ from a patient with any other organ tumor. The reason being that you have to deal with two pathologies. There is a tumor and there is a cirrhosis, and both play at times differently, and the outcome would depend on the interplay between the cirrhosis and the HCC. A decompensated cirrhotic with a small tumor, we may not be able to offer him anything, and somebody who is non-cirrhotic with a large tumor, we can do a curative surgery. So the presence of cirrhosis changes the whole outlook in these patients. We all know the common risk factors are hepatitis B, C, alcohol, NASH, And aflatoxins, again, not very common, but one of the known risk factors for HCC. So what happens is, in the milieu of chronic hepatitis and cirrhosis, there is stellate cell activation which leads to fibrosis and hepatocyte senescence. This creates a milieu which is very ripe for the development of a tumor. And as the cirrhotics are increasing in numbers, as we are having patients who have long-standing cirrhosis, especially in fatty liver, the risk of HCC is also increasing. And finally, there is a risk of advanced HCC. Yes, 10 to 20% of HCC do not arise from cirrhosis, and in that subgroup, the majority of the patients are usually hepatitis B related. So the majority of chronic liver disease leads to cirrhosis and progressive scarring, with the constant inflammation being there, leading to a high cell turnover. It promotes malignancy. As coming to the geographic regions, the major etiological factors, as I said, is Hep B, Hep C, and alcohol consumption, smoking. Metabolic syndrome is increasing in number, and that is one of the important causes we have to keep in mind. One thing is, although anti-HCV, we have been able to eliminate hepatitis C virus, but most of the cases, when they are diagnosed with hepatitis C, already have cirrhosis. So even if we have eliminated HCV, the game is not yet over, because they would still be at a risk of developing HCC, especially in the background of cirrhosis. And that is something gastroenterologists and all other specialties have to keep in mind. We have to keep them under surveillance for development of HCC. So world over, this is the risk factors mainly is hepatitis B in the developing world, and alcohol and others are increasing in number. So if you look at Asia, almost 70% of cases are hepatitis B related. And the same thing, I would say that a similar thing would hold true even for India. And viral hepatitis is the most common risk factor irrespective of the region. And almost 80% of HCC cases are associated with Hep B or Hep C infection. Most HCC cases, even in these viral hepatitis, occurs on a background of cirrhosis. But now, with the changing times, NAFLD, NASH, and ALD are becoming increasingly important risk factors. So previously, one of the teaching was only hepatitis B is one of the risk factors for developing HCC in a non-cirrhotic patient. But now with NAFLD, we have all seen that it is one of the risk factors, and a patient can develop HCC in fatty liver even without the development of cirrhosis. The global prevalence of NAFLD is almost 25%, with the highest prevalence in Middle East and South America, and Africa has the lowest prevalence. In our country, we have a prevalence of almost 30%. So 30% of adult population has fatty liver, and a significant proportion of them would develop end-stage liver disease and cirrhosis as time goes. And it would contribute to almost right now contributes to 10 to 12% of HCC cases in Western population and 1 to 6% in Asian population. But say sitting in a clinic in Mumbai, a more developed part of India, we would definitely see a much larger proportion of HCC developing in fatty liver than Hep B. So even though it shows 1 to 6% in Asian, I think it's increasing, and it's increasing exponentially. Same with alcoholic liver disease. Because of development of cirrhosis, they have a high risk factor of developing HCC. And the annual HCC rate is almost 2.5% in child A and child B alcoholic cirrhosis. So just the last slide, the Indian scenario, as per the International Agency for Research on Cancer in 2020, in India, it ranked 10th amongst all the cancers, with the 8th most common cancer causing mortality, and the 5-year prevalence rate being 2.8, which is significant. In India, I think most estimates would probably say that hepatitis B is the most common cause, but I think fatty liver and NAFLD is one of the increasingly common causes which we are seeing in our country as well. I thank you for your patient listening.
Thank you, Dr. Amit. If there are any questions from the audience, you may ask.
Could you just talk a little about maybe screening in a non-alcoholic fatty liver disease, because we are also seeing a lot of NAFLD, and
Yeah.
do you see your clinical behavior of HCC little different in non-alcoholic fatty liver disease? Because I think that's what we're seeing quite a bit.
I think one of the, again, there is no data to support what I'm saying, but one of the things is genetic. I think there is a genetic predisposition to development of HCC. So at least in my practice, I have 2 or 3 families who have had, 2 or 3 siblings have had HCC in the background of NASH. So there is a genetic predisposition. One of our students did a thesis topic on NASH and PNPLA, but that is the development of cirrhosis. But we still don't know the genetic predisposition, and I feel that genetics play a very important role. So if there is a family member who has developed a NASH related cirrhosis and HCC, it is very important to screen the other members. Especially in liver transplant settings, we see that somebody who comes forward as a donor for a metabolic syndrome related liver disease, the donor himself or herself has fatty liver, which was undiagnosed. So I think one is the genetics. The other is we need not, so there is no surveillance protocol which is different right now for fatty liver, but I think we need to use more of non-invasive imaging like elastography, RF scan, fibroscan, MR elastography to pick up the advanced fibrosis very early. So most of the fatty livers are either like they are ignored, as in this is very common, you don't worry about it. That is not the case. So if the patient is above 45 years of age with multiple comorbid conditions like hypertension, diabetes, basically metabolic syndrome, then we should at least do a basic non-invasive liver related imaging like fibroscan or MR elastography. And if the patient is having advanced fibrosis, then we should put them on 6-monthly sonography and alpha fetoprotein, put them on surveillance for HCC. That is the current, I think, protocol. We still don't have anything different in NAFLD, but I think with more and more research, I think genes, genetic predisposition would play an important role. And if there is a family member with HCC, fatty liver related, I think we should be more aggressive in screening the siblings and next generation. For hepatitis B, absolutely, yes. It is a part of UIP right now. For okay, just screening the entire population, I think universal vaccination at birth or for the entire population? So currently the recommendations are universal immunization for all the newborns and those who are at high risk. So I think as a government program, it is not universal for all the adults, but those who are at high risk, definitely yes, they should be screened and vaccinated. But in India, where it is still a self-driven healthcare country, I think it's a very inexpensive. So I think it's absolutely makes sense that every adult gets tested for hepatitis B, and if he is negative and there are no antibodies, he or she should get vaccinated. But right now, as the national policy, it's only for at-risk population and at birth. At birth, everybody is vaccinated universally. Sorry. Yeah. Thank you. Okay. Thank you.
Thank you, Dr. Mandor. Our next session on the schedule was outcomes of extended criteria for liver transplant. However, Dr. Anurag Shrimal, who is the speaker, could not make it for the program. So we will move forward with the next lecture, that is immuno-oncology for HCC, current status and what to expect in the next decade, by Dr. Ashish Joshi. Dr. Joshi is Director and Consultant Medical Oncologist at Mumbai Oncocare, Borivali and Vilepale.
Hi, good evening everyone. I think I just mentioned before that maybe 10 years back, no medical oncology would be there as a part of the HCC symposium. But certainly now we have treatment options, and then there is a raging debate of liver-directed therapies versus systemic therapy in a potentially inoperable or a medically inoperable advanced hepatocellular carcinoma. So I'll sort of break my talk into these 6 headings. First, we will talk about basic problem statement, IO in first line HCC, immunotherapy in subsequent therapy, immunotherapy in liver-directed therapies or as adjuvant therapy, few briefs about future trends, and then maybe we'll sum up with a quick take-home message. So I think this is a very difficult to treat disease, and as we know that most of the patients, almost more than 75%, would come in an advanced stage, so would eventually receive a palliative therapy. Maybe it's a palliative liver-directed therapy plus or minus systemic therapy. But can we change the course of this illness? Can we improve the quality of life for this difficult to treat patients? Can we take this bull by the horn? Is what the question I think we all, as a caregivers in HCC patients, would answer. These are just basic guidelines. I think all of us do not require any reiteration here. Patients with HCC are broadly categorized into resectable or transplantable, unresectable, inoperable, and a metastatic disease. And I think for this group of patients, which are potentially inoperable or a metastatic disease, would somewhere, the discussion about systemic therapy and a liver-directed therapy would come. These are basically NCCN guidelines which elaborate how these patients are currently treated. You always have an option of loco-regional therapy, which is what is currently preferred and standard of care. But you also have an option of systemic therapy in patients who have refractory to loco-regional therapy or who have got a significantly high volume of extrahepatic disease. Just to brief about the history of medical management of hepatocellular carcinoma, and actually from sorafenib, which happened in 2005, nothing changed for almost a decade or so. Till we got the immuno-oncology drug and a newer TKIs called as lenvatinib, which came into the picture. And if you actually see and get into the evidence for all the systemic therapy in hepatocellular carcinoma, you would see list of negative trials like a laundry list compared with a positive studies which could be seen. And as has been amplified here in this particular slide, all the things which are mentioned in the red are actually the negative studies. There is one non-inferiority studies, and if you could see, the positive studies are far too less. So this is what has been a fairly depressing scenario as far as the systemic therapy of advanced HCC is concerned. But let us look into what new is happening in this ecosystem, and can we improve care for these difficult to treat patients. So up until now, sorafenib was standard of care, and I think all of us know that sorafenib, very difficult drug, probably more than 2 tablets or 3 tablets, very difficult to handle, lot of hand-foot syndrome, lot of mucositis, and hardly see any durable responses. So obviously something was needed in this particular scenario. So came the concept of immunotherapy, and as you know that immunotherapy is making roads in most of the solid tumors, and I think HCC is no exception. So we've got 4 important drugs in the first line therapy, and my topic is going to be on immunotherapy, so I'll restrict myself to immuno-oncology agents in hepatocellular carcinoma. So the first one, of course, is the atezolizumab bevacizumab combination. Then we've got phase 2 study of a drug called as pembrolizumab. We've got Himalaya study with durvalumab and a study on nivolumab. So basically what has been exploited as far as the pathophysiology is concerned is the combination of IO with anti-VEGF, because overexpression of VEGF inhibits the immunity, or rather stimulates the immunity in the tumor microenvironment, and if you inhibit that, then probably the immunotherapy drugs will act better. And similar thing happens in PD-L1 CTLA-4 combination. So this is basically the pathophysiology on which the pharmacodynamics and the new drug delivery has been built in. So the PD-L1 anti-VEGF combo, we have got atezolizumab bevacizumab, we have got atezolizumab cabozantinib, and we have got pembrolizumab plus lenvatinib. And PD-L1 anti-CTLA-4, we have got nivolumab ipilimumab, and the durvalumab combination, which is resonating in the landscape of the treatment of advanced HCC. So of course the torchbearer of this particular concept is the Embrace 150 study. This was the study when atezolizumab plus bevacizumab was combined and was compared with the standard of care, which is sorafenib, and the primary endpoint was overall survival and progression-free survival, and the secondary endpoints were obviously toxicity and the response rates. The point to note that the baseline characteristic was similar, but there were a lot of patients who had a high volume of extrahepatic disease and a vascular invasion, which are typically difficult to treat disease, and a significant vascular invasion will actually prohibit us from giving good liver-directed therapy, especially the TACE. So these are the patients wherein we have very limited treatment options. So atezolizumab and bevacizumab included this particular group of patients as well. And if you could see, as we move on, these are the highlights of the patient characteristic. Patients with efficacy in this, patients with have got microvascular invasion or extrahepatic disease, there's a conspicuous difference between efficacy of sorafenib versus atezolizumab plus bevacizumab. If you could see the median overall survival of 13.5 months, almost doubled compared with sorafenib with a hazard ratio of 0.48. Even the median progression-free survival was significantly more in patients with atezo-bev combination in this group of patients vis-a-vis those patients who had received sorafenib. Again, overall response rates were superior in the patients with combination of atezolizumab plus bevacizumab compared with sorafenib, and this is the primary analysis of overall survival and progression-free survival. Again, a very, very impressive hazard ratio. Mind you, we didn't have many treatment options before sorafenib, but this is one trial which has shown that there is a significant overall survival as well as progression-free survival benefit with a combination of atezolizumab plus bevacizumab compared with sorafenib. A very important disclaimer that both these regimens are to be used only in patients with Child-Pugh A liver function, and they have not been tried in the patients with Child-Pugh B. The only probably there is some data of the SHARP study wherein patients with 120 patients had Child-Pugh B function, so there is some evidence that maybe sorafenib could still be tried, but we do not have any evidence to support the use of atezo and bev combination in a patient who had got a decompensated liver cirrhosis. The safety profile, there has been a lot of noise about use of bevacizumab and bleeding risk, because bevacizumab being anti-VEGF agent predisposes for bleeding. But the safety profile was fairly manageable, and as I will expound in few of my next slide, that there has not been significant or alarming increase in the bleeding risk. And it's very important that when we put the patient on atezo-bev combination, we need to get an endoscopy done just to see the status of the varices, because many of these patients would have portal hypertension, which is not captured in the Child-Pugh classification of liver disease. So this is the rates and the grades of the bleeding, and as you could see, I think very similar across the subgroup. So there has not been any alarming increase in the risk of bleeding with the combination of atezo and bevacizumab. Also, it is important to note that the atezo-bev combination has not been tried in the patients with co-infection of hepatitis B and C together, but they could be used in the patients who have got either hepatitis B or C, but not those who are co-infected, because the safety profile in this group of patients is not yet been proven. The second drug, of course, is the pembrolizumab lenvatinib, which is again a negative study. It was a phase 3 randomized study of pembrolizumab plus lenvatinib, and the primary endpoint were PFS and OS. And if you could see, there was a durability response which was achieved, but it did not meet the pre-specified statistical significance. So in a way, if you look at this, was a negative study in terms of efficacy and in terms of the primary endpoint. Again, then we have a pembrolizumab monotherapy in the first line setting, which is the Keynote 224 trial. It was a phase 2 study. Again, there was no comparative one. The aim of the study was to assess the durability of the response. And if you could see here, the achievement of the response is there, but again, there is no comparative study and there is no obvious PFS and OS benefit in terms of efficacy. So again, a weaker evidence though, but can be considered, and the conclusion is that after 2.5 years of the additional follow-up, pembrolizumab continues to provide durability of the anti-tumor activity and no new safety concerns were identified. Again, echoing the same concept that immunotherapy has got a long tail, and if somebody who responds to the immunotherapy, then the durability of the response is very, very good, and that's what makes these agents attractive in the treatment of advanced metastatic solid tumors. This is again a very interesting study where there is a combination of anti-PD-L1 and CTLA blockage which has been exploited. A drug called as durvalumab, which is a anti-PD-L1, along with tremelimumab, which is CTLA4, an inhibitory antibody, which was combined and was compared with sorafenib. This was again a multicenter randomized open phase 3 trial. It had got 4 arms, and the conclusion for the ease of my audience is that durvalumab was non-inferior to sorafenib, and the combination was actually superior to sorafenib in terms of efficacy. Again, if you have somebody who is has a toxicity concern with sorafenib, then durvalumab monotherapy could be a reasonable combination in this group of patients, again highlighted by this particular study, which has got 3 treatment options of durvalumab alone, durvalumab with tremelimumab combination, and sorafenib as a reference arm. The last one, of course, in the first line was the CheckMate 459 study. It was nivolumab versus sorafenib, again first line treatment option. And just for the ease of conclusion, the primary endpoint of overall survival did not achieve statistically significant, but it showed meaningful improvement in the response rates, overall response rate, complete response rates in the first line treatment of HCC. But I think with the advent of EMBRAVE 150 study, atezolizumab, bevacizumab has taken over as the most important treatment option in the first line treatment of hepatocellular carcinoma. The IO has also been studied in the subsequent therapy, and there have been 4 drugs which have been studied. One is nivolumab, pembrolizumab, nivolumab, ipilimumab combination, and dostarlimab in various settings. Not go into the too much of trials. They have shown durable response rates, but none of the studies have shown a significant improvement in the overall survival or progression-free survival as far as the treatment efficacy is concerned. But again, post sorafenib, there are options which probably few years back we did not. These patients would easily go on to base supportive care, but at least those patients who have got preserved liver function, you have option of immunotherapy agents post sorafenib in the treatment. At least they have got fairly controlled durable response rates, not significant improvement in the overall survival, but there has been some data of improved in the progression-free survival for this group of patients. There have been some studies of IO-directed therapies along with liver-targeted therapies, and I think that's been going to be a detailed about panel discussion, so I would not dwell too much into it. But if you could see here, this is a meta-analysis showing the hazard ratio in the both first line and the second line setting. Probably it's still, jury is still not out, but probably systemic therapy is making its way into the scenario wherein there is a inoperable HCC, you have an option of liver-directed therapies. Probably a good systemic therapy option could challenge some of the indications of liver-directed therapy, though liver-directed therapy continues to remain a standard of care for this group of patients. There have been interesting trials which are going on currently about combination of TACE with immunotherapy, and I think we should hear soon about interesting results. I think the designs are very, very similar, that you have a liver-directed therapy followed by adjuvant immunotherapy, and could still be, because we still know that even after liver-directed therapy, large number of patients are going to relapse either locally or systemically. So probably could you do better for this group of patients, and probably in next few years, probably these studies would highlight as to how do we titrate these patients and how do we treat them. Future trends, again, there have been studies which are going on in the adjuvant setting, and in fact there is one Korean study which is positive in adjuvant setting post liver resection, but again that's not the standard of care. But you've got studies which are going on which are comparing various IO agent in the adjuvant setting. Again, as I mentioned, there is a combination of TACE with IO, and there are a couple of studies which are still going on in this space. And in the advanced setting, apart from the studies which I have mentioned before, there have been few more studies which are going on in various IO immunotherapy along with the anti-VEGF agents or IO plus CTLA4 blockade to enhance the efficacy of the treatment that we already have. So this is what, as we stand as of 2022, these are the ASCO recommendation that the patients who have got advanced inoperable disease, typically if there has not been any contraindications with atezo-bev combination, somebody who has got childhood A, then atezo plus bevacizumab becomes a standard of care. The problem happens is that those patients who will progress on this first line of regimen, there is no standard of care. There has not been any data, or there has not been any molecule which is supposed to be resonating in this group of patients. And as we start using this atezo-bev combination in the first line setting, I think this problem will have to be encountered, because we really do not have a standard treatment options for these patients. Those patients who have got contraindications to atezo-bev combination, then probably TKIs, either sorafenib or lenvatinib, both are reasonable option. Probably lenvatinib has got better side effect profile. And those who will progress, and eventually all of them would, then probably we have got second line treatment option in terms of cabozantinib, regorafenib, ramucirumab, Here we have an option of immunotherapeutic agent like pembrolizumab monotherapy and nivolumab monotherapy in this particular group of patients who have progressed on first-line tyrosine kinase inhibitors. So systemic therapy in hepatocellular carcinoma in 2022, I think atezo-bev would be very important treatment options. Again, childhood A patients who do not have contraindication, sorafenib and lenvatinib are always in the treatment options. Again, mind you, this is not applicable for patients who have got decompensated liver cirrhosis. So nothing for as such for childhood B, though up to B7 sorafenib could be tried, but nothing for any advanced patients. And those patients obviously would progress on this combination. Then you got option of regorafenib, cabozantinib, ramucirumab. Also, there have been some data of monotherapy with other IO agents like pembrolizumab and nivolumab in this space. So my take-home message is that introduction of immunotherapy at least has created some reasonable treatment options for this unresectable, difficult to treat metastatic HCC. IO in combination with anti-VEGF and CTLA4 inhibitor, there is a biological rationale to exploit it, and it is reflecting in positive studies. IO is emerging as one of the treatment options along with the liver-directed therapies and adjuvant therapy. Again, not a standard treatment in terms of systemic treatment options. It's an unmet need, and the trials are going on. And sequencing of therapy will be a challenge, especially with the first-line IO therapy options, which is being very commonly used in the treatment of hepatocellular carcinoma. With this, I conclude my talk, and I thank you all for patient hearing. Thank you.
If there are questions in the audience.
Yeah, yes.
Ashish, at what time intervals do you check for progression, and what is your definition as an oncologist of first line, second line? Is it a duration based response, or what type of imaging you do for seeing whether we have to change to a second or a third line agent?
So first line therapy is somebody who has not received any systemic therapy. So somebody who has received TACEs doesn't become a first line. It becomes a first line. Somebody who has received a liver directed therapy and has not received any systemic therapy becomes a first line therapy option. So typically in medical oncology, what we do is we check the liver function test. Somebody who has got a compensated liver disease, childhood A, and there is no contraindication to bevacizumab atezo combination, we do an endoscopy. Then that could be the standard of care. Of course, there's a financial concerns which would be associated with it. If not, usually lenvatinib or sorafenib. Nowadays, lenvatinib becomes the standard of care. The way we monitor is alpha-fetoprotein and CT scan. PET scan typically is not recommended for hepatocellular carcinoma unless you want to rule out there is a significant extrahepatic systemic disease. 6 sessions is what we use because there's a patient
6 sessions you are going to redo the.
Because there's a PAP, so that 1 + 2 is free. So we give 2 atezo, and so we cover with 6 cycles of atezo plus bev combo, and then after that evaluate. Unless there is obviously some signs of disease progression intermittently.
And what is I have seen one of your patients getting autoimmune hepatitis because of these new agents. So what is the incidence and how do you are managing?
So typically, except for autoimmune pneumonitis, most of the autoimmune phenomena associated with IOs come post 3 months. They do not happen in first 3 months. So that's not an immediate concern. Also, if you see the label for nivolumab as well as atezo, since some of these patients would have deranged liver function test, the dosage modification is been defined. So depending on those, we take a call. But we've seen some amount of autoimmune hepatitis in patients who are not HCC patients, in other solid tumors, wherein typically, depending on the grade of hepatitis, either it's a dose reduction or treatment discontinuation, and also there is a use of steroids that would be used, and that's common with most of the IO agents. So grade 2, grade 3 onwards, if the systemic IO side effects set in, then discontinue the treatment, give us course of steroids is what the standard of care.
So Ashish, if the AFP is increasing or if it's not decreasing, so what are how do you monitor that progression? As in what do you expect the AFP to and how do you see, because we all know that you follow the MRECIST criteria only in the imaging.
Yes.
And so what would you do if the AFP is not decreasing, in the sense, because many of the patients are still continued on the same therapy in the sense, and
yeah. So even a stabilization of disease is good enough for us to continue with the treatment. because if you see, even if with the IO BAVE combo, the response rates are not phenomenal. So even if you achieve a disease stabilization and the quality of life is maintained, and on the resist there is no new lesions or there is no frank progression, then it may be reasonable to continue the IO BAVE combo.
But how many actually in practice do you get patients who are actually child class A and they do not have any extra hepatic spread? And there would be also progression in terms of cirrhosis where you'll have limitation to use these agents.
Absolutely, I think that is a very right question. And in clinic, to get a patient with well-preserved liver function and advanced disease, it's uncommon. Many of our patients typically actually have got a fairly advanced decompensated liver disease. We still try lenvatinib or sorafenib in this group of patients, but eventually they go on to best supportive care.
I have a little different take. I think we are seeing a lot of patients with child A with a significant tumor load, and I think it's cost is one of the factors. In fact, if cost can come down, a lot of patients would actually, especially with portal involvement. So, in fact, just one question is a combination of tastes. So, do you follow the Apple consensus? Like, at what stage would you ask your interventional radiologist to be the first one to intervene, or would, like, if the patient comes to you, when would you refer your patient to an interventional radiologist, as in especially if it's an intermediate and advanced, so those subgroup, like, how would you decide which patients go for an loco-regional versus a...
So somebody who has got a very limited extrahepatic disease and a very limited portal vein invasion, these are the patients who could still go in for a liver directed therapy. Those patients who have got a significant systemic disease and a high tumor burden out of the liver, and those who have got a major portal vein involvement, I think that's something is going to be a subsequent talk, that even in those settings, liver directed therapy still could be done. But these are the patients wherein you would opt out for a systemic therapy options.
So just to comment on Amit's question, I think as you pointed out towards the end of your presentation, I think the future will be a combination of liver directed with systemic therapy. And I think that's what we are already moving towards.
Yeah. So there are not been any major alarms or red flags when you are using immunoagents in older patient. In fact, for patients in older adults, it's a very attractive treatment options because it doesn't have the side effects of a cytotoxic chemotherapy. So we do not really encounter something different in older adults as far as the IO is concerned, and it's very well tolerated. In fact, for lung cancer patients, I think immunotherapy has become a huge attractive option for our older adults, and that's true across solid tumors.
If you don't mind, can you let us know what is the cost of therapy which actually comes in practice?
So atezolizumab cost upwards of 3,40,000 rupees, around that, for one atezo, and it's a flat dosing of 1,200 milligram. But they have a patient assistant program that after you buy one, you get 2 rounds free. So BAVE is no BAVE is something which come, but BAVE is available in generic form as well, and I think they have some PAP for BAVE also. Yeah. Yeah. So the first cycle, along with atezo, you get bevacizumab also free because it's still a Roche product, so that comes. So eventually, if you look at a cycle, would cost around 1.5 lakh of rupees if you add a PAP. So it 1 + 2 free. So that's the way typically a patient is counseled, that you go for the 6 sessions, so that you have to buy the 2 drugs and we analyze the response.
I think till now the radical therapies only were able to give survivals in years in HCC.
Yeah.
In last few years, actually, many systemic therapies have come, and now, like the recent atezo trial, they shown survival up to 1.5 years. But it's important to know that is that not all patients like survive till 19 months. So it has to be like specific and selective patient selection as per the trial criteria. So if you go especially exactly by the trial criteria, then also not all patients will survive till 19 months.
Absolutely.
But practically in our day-to-day practice, very few patients actually are in CPS stage, right, to score A. So many times we have to stretch the guidelines, and we end up giving these therapies in patients who are child-free early, like because the trials have included only those patients which are expected to give best outcome. But in clinical practice, we don't see all those patients. On the contrary, in this part of the world, we see patients who are quite advanced in stage. So, but as per our clinical experience, sometimes we feel that the liver functions are intact, and we may try these agents. Like even those TKIs, sorafenib and lenvatinib, they also are recommended only for Child-Fuchs A. But I think like most of us are using these agents in Child-Fuchs B also, and we all know that these agents have worked, and we have been able to prolong the survival. Like at least those patients who are like in BCLC C. So many of us have been able to see the patients surviving for at least a year when they have not been suitable for local therapies. So like many times we need to stretch the guideline, and we need to give therapies to eligible patients. So obviously cost is a serious concern. So that's why.
So I think the TACE plus sorafenib trials have been, there's no consensus. So that's still not a standard of care, because 2 trials were negative and only 1 trial did show some improvement. But probably with the IO coming in, maybe there could be an improvement in the outcome.
I have a quick comment to make here.
Yeah.
Recently, 2022 or late 2021, we had a landmark study called Legacy study coming in from, it was a multi-center trial for radioembolization of solitary hepatocellular carcinoma up to 8 centimeters in size. And it is for the first time that TARE or radioembolization could make a way up to the BCLC algorithm.
Okay.
Till now, BCLC did not include TARE because there was no concrete evidence, there was no level 1 evidence for TARE. But with the consistent efforts of few groups, European as well as North American, now TARE has come into the picture, and this has all been possible because now we are able to do personalized dosimetry for every patient and deliver a high dose intra-arterial brachytherapy to the tumors. I'm going to talk about portal vein thrombosis,
Yeah.
but that is actually not a great group, that's a dismal group after all. But we should look at tumors where without portal vein thrombosis, where we can really make a great difference. And I request all of you that you should please go through the this study, and probably that will have a lot of impact on how we treat patients with HCC. Thank you. Yeah, so recently there has been a randomized study comparing drug-eluting bead chemoembolization and transarterial radioembolization, and the study was halted in between because radioembolization was definitely associated with better tumor control, local tumor control, better time to tumor progression, safety and toxicity profile, and improved bridge to resection, transplantation, and hence improved survival. So cost is an impediment, I agree with that, but if that is, we can work around that, probably we'll have better results in many patients.
Can we repeat the TARE?
No. Sorry?
Can we repeat the TARE?
We hardly have to repeat TARE. It again depends on what group of patients we are looking at. If we have a 4 centimeter size tumor and we are able to give high dose radiation to this tumor, most often the patient will be downstage to surgery, or sometimes even without surgery, if he is not a surgical candidate, we get very good responses in these patients.
So just to stretch this, and we have had this many real life cases. Up till now, liver transplant is a complete no-no for main portal vein thrombosis, VP3, yes. VP4. VP1, VP2, we have evidence that transplant does well if there are certain criteria met. So as the oncology, and you all know the principles of oncology much better than us. So for example, if there is a patient who has a main portal vein, and we have had cases where with combination of TARE or sometimes even with systemic chemo, there is complete resolution of the tumor thrombus. And if we have say a waiting period of 3 to 6 months, there is still no data as this being these patients. There are case reports of some being transplanted and having done well.
Correct.
But considering the principles of oncology, would this be a subgroup where transplant can be considered? And we have all seen these patients who have done very well, I had one patient with an alpha fetoprotein 1 year back of 3,200, main portal vein involved. With 6 cycles of beva-atizo, the alpha fetoprotein came to 6. Then he developed nephrotic range proteinuria, so it was stopped. Now on Lenva, after 3 months, again the alpha fetoprotein is 22. The portal vein is now like a bland thrombus, non-enhancing.
Right.
Is he a candidate for transplant oncologically?
So maybe, so I think these are encouraging anecdotal reports, but I think it's still a little premature to, I mean, having worked in transplant units before and also doing oncology now and over the last 20 years. But I think a lot of these patients in the future will recur. I think yet, unless, post-transplant probably, because finally we have to, tumor biology I think is something that we, finally is very difficult to fight. And while you will have the 1 odd case who will do well, you will have the 9 odd ones who will probably not. So I think it will have to be a much larger cohort of patients to then finally get to the point where we make it. Of course, in India, transplant is considered for patients, since it's a predominantly living donor program. I think a lot of rules are bent. But I think the key will be, will this patient get onto a cadaveric list anywhere in the world? And I think that will answer your question.
So I think we're looking at a concept called as operational cure, and that's happening in across solid tumors in advanced and hematological malignancies because of the effectiveness of the regimen. But then again, whether to include these patients. So typically what we do in solid tumors, those who have got systemic disease and we started systemic therapy and have responded well, we usually see the durability of the response. And if the duration of the response is very good, then probably it's worth exploiting a good loco-regional therapy. So it depends. Of course, there is no magic formula. There are no rationales. There are no guidelines. I think the biology of the tumor will possibly dictate. But typically in breast cancer, say for example, somebody who's got an oligometastatic disease, we keep them maybe 6 months, 8 months. It's not very long for metastatic breast cancer as such. We get the mastectomy or a local therapy done. But then it's easy for a local therapy to have been done in a patient with breast cancer, and that's a little challenging in a patient with hepatocellular carcinoma. I think, but conceptually you're right. I think there will be a time when you would have a patient who has got a deep punchy response, and then he could be exploited for a loco-regional therapy. Yeah. I think the want of time should be.
In the interest of time, we can take the questions later. I am announcing the next session on SBRT for hepatocellular carcinoma, current scenario and future trends, to be taken by Dr. Kaustav Talpatra. Sir is a director, radiation oncology at Nanavati Max Super Specialty Hospital.
Which one?
At the outset, I would like to thank Ganesh, Ashish and MOC for this opportunity. My talk is Emerging Role of Precision Radiation in HCC, the Current Scenario and Future Trends. So, before getting on to specifics of HCC, first let me just introduce what is stereo, because this is a multidisciplinary crowd. What is stereotactic body radiotherapy? The stereotactic radiosurgery concept started from brain, and now it has come to body. Body doing stereotactic radiosurgery is more difficult because of moving target. Liver is a mobile organ. It's not a stationary structure like brain. So what is stereotaxy? It's a method of delivering very high external beam radiotherapy accurately to a extracranial target in one or few fractions with a very high dose of radiation. And when we talk about accuracy, it has to be accurate and not only precise. Let me explain the difference between precise and accurate. Precision is you are going on hitting the same target, but that same target may not be your target. So you have to be accurate as well as precise. So you, in the first image, you are precise. The first one on the left-hand side, you are precise. But here you are precise and accurate. So SBRT is a very accurate way of delivering radiation. And why we need so much of accuracy and precision is because our body is in 7 dimensions. We are not in 3 dimensions. We are not just in X, Y, and Z coordinates. We are also in the roll, pitch, yaw, and the motion of the liver or any other organ, and the real time is in 7 dimensions. It's not in 3 dimensions. So while doing SBRT for liver, stereotactic body radiotherapy for liver, we have to take care of all those 7 dimensions of motion, and that has been the most challenging thing over the last 3 decades, which we have managed to overcome, that how to mitigate not only the XYZ coordinates, but also the rotational motions and also the real time with the advancement in technology. So what is stereotaxy? It is understanding the biology, that it is radiation not only works by DNA damage, but there are various other mechanisms happening, like vascular changes, apoptosis, immune responses. It is important to identify the target with physical and biological imaging, and the delivery has to be precise, accurate, and safe. So you have to integrate spatially various other modalities with stereotactic body radiotherapy, not only radiation, which we'll be talking about, and the outcome measures have to be with hard endpoints. So now talking about SBRT specifically in hepatocellular carcinoma, talking about background, I think the background has been very nicely discussed, so I will skip the slides. We also understand that treatment of HCC is challenging because not all the patients are resectable, and surgical resection or transplant, though considered curative options, are not always possible due to all these reasons. Historically, external beam radiation has not really worked in liver because of very low doses used, whole liver radiation used, and because of primary concerns of radiation-induced liver diseases. But with focal radiotherapy, incidence of RILD has significantly come down. Now talking about the indications and the inclusions and the exclusions, we all know the BCLC staging, and this is one publication which was published in Seminars in Radiation Oncology. And if you go through NCCN, NCCN has now included SBRT in its last 3-4 publication, and where RT fits in has been very well described in this article. So what are the indications of radiotherapy? Patients with BCLC-A who are not eligible for surgery, TACE, RFA, or failed TACE and RFA should be considered for liver SBRT. In case for portal vein tumor thrombosis, it's an extremely effective option. SBRT may be used as a bridge to transplant if discussed within a transplant MDT. Emerging role of SBRT in oligometastatic extrahepatic disease and recurrent tumor as salvage therapy. So in recent years, use of SBRT has increased as a result of its favorable therapeutic ratio, and overall median survival in various studies which we'll be going through has been to the tune of 13 to 45 months. In BCLC-C also, that is patients with vascular invasion, there have been studies which have talked about 10-month survival with SBRT. So these are the inclusion criteria: Child-Pugh, A5, A6, and select B7, good ECOG, BCLC stage A, select B, which I have talked about, and C only for portal vein thrombosis. Maximum tumor size less than 10 centimeter, preferably less than 8 centimeter. No more than 3 intrahepatic foci of radiologically confirmed active HCC. Adequate normal functioning liver, that is liver minus the gross tumor volume for radiation should be 700 cc or higher. No extrahepatic or abdominal nodal metastasis, and distance from the bowel, stomach, or duodenum should be at least 1 centimeter. And we have to be very strict about the selection criteria. If you do not select your patients well, you will have morbidity, you will have recurrences, and that's when all the problem starts. And of course, if those were the inclusion criteria, these are the exclusion criteria which have been enlisted. Evidence talking about BCLC stage 0 and A. Of course, RFA, because of its prolonged, I must tell that IAEA wanted to embark upon a trial of SBRT versus RFA, but Dr. Anirudh never sent IAEA the patients. So Dr. Anirudh has been holding all the patients. I mean, not to say Dr. Anirudh, but all the intervention radiologists. So I urge them to be fair and get on to a randomized control trial and let us see the evidence by itself. So the application of RSA often, of course, intervention radiologists may have a different take on it, but heat sink effect, it may be not in Dr. Anirudh's hand, but in a lot of hands, hilum or dome of the diaphragm may have risk of complication, and if the tumor is large, the outcome is poor. So this is the evidence in stage 0 and stage A. Retrospective study, Matthew, single arm, high risk, 3-year OS was 39%. Korean study, small HCC, treatment naive, refused all other treatment, 5-year local control was 91 and 45%. In the definitive setting of early stage 0 and A, the meta-analysis by PAN, which included 10 studies, compared SBRT with RFA for treatment-naive HCCs, and there was superior 1 and 3-year local control with SBRT. The 2-year overall survival was slightly better with RFA, but due to variation in baseline liver function. But after eliminating reporting bias, the secondary analysis showed equivalent 2, 3, and 5-year OS. Similarly, Kim et al. Also did a phase 3 randomized trial, and the 2-year local progression-free survival was with SBRT was with the portal vein brachytherapy was non-inferior to RFA. In intermediate stage, TACE is again the evidence-based treatment modality because most of the SBRT trials are phase 2, and we have embarked upon some phase 3 trials. Having said that, few trials which compared SBRT and TACE, like in this study, the first study on the left, SBRT was actually statistically significant in a propensity score analysis of 209 patients with 1 to 2 patients who had 1 to 2 tumor. Similarly, there have been other studies, but what is important is there is 2 ongoing randomized trials comparing TACE and SBRT. One of them is accruing very poor, so I urge Dr. Anirudh to send some patients for that trial so that we can complete the study. Actually, IAEA is, it's not us, it's IAEA who is conducting that study. So this is the recent prospective and retrospective study which has shown, you can see the doses used here, you can see the local controls, and most of them have a 2-year local control up to 85 to 90%. Grade 3 toxicity, the earlier studies were to the tune of 16 to 20%, but now they are to the tune of 5 to 7%. Role of SBRT in HCC with portal vein thrombosis. We have discussed SBRT works wonder with portal vein thrombosis. The point which was being discussed, there are 2 issues here, technicality and the overall oncological outcome. Technically, what percentage of patient can be transplanted after SBRT? Around, in few studies, 40 to 50%. These are the studies. And 40 to 50% of the patients have managed to get a transplant. So see here, in this 14 out of 24 patients, similarly 12 out of 18 patients have managed to undergo transplant. So that is one thing of technicality, whether transplant is feasible or not. Answer is yes. SBRT will make 50 to 60% patient transplantable. The next question is, as Dr. Ganesh rightly pointed out, we have to look at just because we have done a transplant, do we omit the chances of a florid disease or metastasis? That is something which is a point of discussion, and we need to look into. A small overview of SBRT workflow. So first, the patient is simulated. What is simulation? Is before radiation you exactly simulate and do a scan, a biphasic or a triphasic scan of the tumor while the liver is moving, or deep inspiratory breath hold. So if you are doing a 4D scan when the liver is moving, you take image set and bin them retrospectively. So you take an image set at 80-10, inspiration, expiration, 70-20, 60-30, 50-40, like that. Sets of 10 of inspiration, expiration. You bin them, and your computer system has way to generate an internal target volume while the liver is moving. Because if you place static beams, you would be placing beams and you will be missing the liver when it was in a different inspiration expiration phase. So you have to generate an ITV. Or you make the liver static in one phase, which is deep expiratory breath hold or deep inspiratory breath hold, and ensure that your machine fires, which is called gating, only during that phase of respiration. So after planning, you do motion management, you draw the tumor with the help of image set. Of course, you involve a multidisciplinary team. You draw out the target, you deliver the beam, you see what is the dose to the critical structure, quality assurance, and while delivery also, you do motion management on the machine. So that is basically the workflow of SBRT. SBRT for central lesion, yes, it is feasible if you use a lesser dose like 40 grain, 5 fraction, because central biliary structure you have to take care, like gallbladder, common bile duct, right hepatic duct, left hepatic duct, and cystic duct. What is the future? Combination of SBRT with TACE, immunotherapy, and targeted therapy. Combination space is very important, as we have discussed, that each patient is different, and if a patient is not being operated, there will be almost 40 to 50% of patients who will not be straightforward and who will require combination of therapies. SBRT plus targeted therapy in HCC, of course, there is data with sorafenib, which is the overall survival was 15.8 months with addition of SBRT versus 12.3 months, which is statistically significant. And there are various other trials going on, which I'll be talking about. Toxicity, no radiation talk is complete without talking about the toxicity of radiation. So RILD is the most dreaded toxicity. You should have adequate normal liver, which is not receiving radiation dose. Our dictum is 700 cc of normal liver should be there, which should receive less than 15 ray of radiation dose. And ideally, you should have more than 1000 cc of normal liver minus PTB, at least 700 cc. The rare toxicities are fistula, bleeding, ulcers. And of course, there are biliary tract toxicity, chest wall toxicity, depending on the location of the tumor. The current status, ongoing trials of SBRT and immunotherapy. There is, at Mass General, there is a phase 2 trial going on. At UKH, there is a phase 2 trial going on. And estimated enrollments have been listed. Most of these trials mostly will be accruing up to 2024. So by 25-26, we will have some data and some results. As I said, NCCN has incorporated SBRT in its guideline. So it is an alternate treatment modality for HCC today. Take-home message. The current evidence, yes, SBRT is feasible, it is non-invasive, and with so much of data generated around the world, now the toxicities are really acceptable. Efficacy, definitely the local control rates are efficacious. Future direction, randomized control trial with other local procedures and integration therapy. Thank you.
Thank you, Dr. Talapatra. In the interest of time, we'll take the questions probably in the panel discussion or maybe later. I am announcing the next session. Outcomes of TARE in hepatocellular carcinoma with portal vein thrombosis, to be taken by Dr. Aniruddha Kulkarni. Sir is a Director, Vascular and Interventional Radiology, Nanavati Max Super Specialty Hospital.
There, no? Okay. Good evening, everybody. My talk is going to be very crisp, concise, short and sweet. treatment outcomes of patients, HCC patients with portal vein thrombosis. For a very long time, the answer to this question has been that the treatment outcomes are dismal. But we have not stopped trying. And one of the first cases which really got all of us interested in transarterial radioembolization was a case which has been published, absolutely an anecdotal case by Riyad Salem, to whom we owe a lot of our knowledge of radioembolization, wherein he had a patient with large HCC with portal vein tumor thrombosis involving the main portal vein. After one session of radioembolization, to his surprise, not only did the tumor respond, but the portal vein tumor thrombus completely disappeared. This patient underwent liver transplantation. And he has shown this case to all the interventional radiologists across the world and to many people. And he has also published it. But he also mentioned that, and in his publication it is written that 3 years down the line the patient recurred. And where did he recur? It was at the anastomotic, portal vein anastomotic site. So like Ganesh was saying, that the battle is not over even if you are able to transplant these patients. But our understanding of radioembolization, the dosimetry and the response rates is improving, and probably we are getting there, and probably we will be able to improve the survival of these patients. This is a busy slide as usual. What I want to draw your attention is to this. If patients are not responding to TACE and have a tumor which is less than 8 centimeters in size, we can consider doing TARE, and this is a part of the BCLC guidelines now. Portal vein tumor thrombosis, macrovascular invasion, we know is an extremely poor prognostic factor, and the moment the patient has this, you straight talk of systemic treatments according to the BCLC guidelines. But people have tried to do things out of these guidelines and have reached somewhere, and we need to see that. So interventional radiology, thank you Kaustav for saying that we control the flow of patients, and we wish that it is the interventional radiologist who controls the flow of patients, but it's just a joke, and it is a group decision and team effort always. We have ablation, transarterial therapies, systemic chemotherapies. The aim of all these treatments is to try and bridge the patient either to resection or to transplantation. I don't know how much we have succeeded in bridging a patient to transplantation, but certainly for some patients we have been able now to bridge the patient to resection. This applies to patients who do not have macrovascular or portal vein involvement. The moment we have portal vein involvement, obviously the results are getting poorer and poorer. The transarterial therapies are the only option for patients who have portal vein thrombosis. Chemoembolization relies on injecting chemotherapeutic agents and blocking of the blood supply and causing ischemia to the tumor as well as to the surrounding liver parenchyma. In the presence of a tumor thrombus, the liver parenchyma becomes dependent on the hepatic artery apart from the tumor. So the moment we block this, these patients tend to decompensate. Therefore, this is not a great option for patients who have portal vein tumor thrombosis. Does it mean to say that we cannot do this for patients who have portal vein thrombosis? That is not the case. So patients who have branch portal vein thrombosis, we can still offer them chemoembolization, but the results are not great and they do tend to decompensate. Whereas radioembolization, which employs yttrium-90 particles, the particle size, the glass beads or the resin spheres are 30 to 40 microns in size, and they penetrate deep and lodge in the tumoral microcirculation at the level of the arterioles and irradiate the tumor parenchyma from inside by beta radiation. So they have an exponential decay and give a sustained effect, and we are able to really assess the response at 3 to 6 months with radioembolization. So radioembolization is, even though we say it is embolization, it is a minimally embolic therapy. So if you look at the pre and post angiograms after radioembolization, the pre and post angiograms look almost the same. That is, the arteries look the same and they do not get blocked. This is also a biological advantage because radiation wants normal oxygen tension. So this is one of the reasons that radioembolization is done like this. So just to show a diagrammatic representation, with transarterial embolization we get proximal occlusion of arteries. Similarly with depth test, whereas radioembolization the particles tend to penetrate deep and give a sustained effect from inside. Just to show you a case, it's a very, very advanced disease, large tumor with portal vein tumor thrombosis. This patient was known to me actually, a close family friend. His general status, general condition, ECOG performance status was not that bad. Liver function test, in spite of such a huge tumor, were fairly well preserved. This is the planning angiogram. So what I was trying to talk about, the personalized dosimetry, this is the planning angiogram, where we see this tumor in the right lobe being supplied by the left hepatic artery, the gastrohepatic trunk. So after we do map the arterial anatomy of the tumor, we inject technetium labeled macro aggregated albumin in the hepatic artery and see how much of this is getting shunted to the lung. So this is one of the key rate limit or the dose limiting factors in patients with HCC with portal vein thrombosis. If we have shunting within acceptable range, that is up to 8 to 10%, we can give a good dose to the tumor. Another problem in patients with portal vein thrombosis is that the primary tumors tend to be large. That is another thing which tends to limit the dose. So when we heard, or I'll just come to that. Okay, so this is another huge area of tumoral supply from the replaced right hepatic artery. This is how this we had done with SIR spheres. This is how the typical radioembolization kit looks. This is the lead jacket to protect the operator as well as the patient from radiation dose. This is, and after radioembolization, this is what we got, partial necrosis. This was a huge tumor, of course, we did not expect much, but this patient went on to live for 13 months because his Child-Pugh status was Child-Pugh A. So when we saw Riyad Salim's first case, and we were really excited and thought that, we have found an answer for patients with portal vein tumor thrombosis. But his results published in 2010 showed that there are two things. One is you look at the Child-Pugh status of the patient. Patients who had Child-Pugh A, their prognosis was slightly better, wherein they survived up to, the median survival was 13 months. Whereas patients who had portal vein tumor thrombosis and Child-Pugh status B, the median survival was 8 months, which was marginally better than patients who did not receive any treatment. European group now has come up with their own results, and with median survivals up to 18 to 20 months, and that has been based on personalized dosimetry. So with this, what we are doing is that we are going deep inside the arterial tree and dividing the doses of yttrium into 2 or 3 arteries, wherein we can give very high dose to the tumor parenchyma. Another thing that matters and is having an impact on the dose, on the results, is ability to deposit Y90 in the portal vein tumor thrombus. It is not very often that we find discrete branches going into the tumor thrombus, but if we find discrete branch going into the tumor thrombus, we tend to cannulate that branch and deposit Y90 in that branch. So if we have patient who has branch portal vein thrombosis, a favorable Child-Pugh score, and tumor dose of at least 205 gray, which we are now able to calculate. Earlier, the Riyad Salim's publications were at a blanket dose of 120 plus minus 20 gray with a fear of toxicity, and slowly now they have stepped up, and they have found out that at least a dose of 205 gray, if we are able to inject in the tumor parenchyma in patients with portal vein tumor thrombosis, we are able to prolong the survival. Even if the tumor thrombus doesn't disappear completely, it becomes a non-enhancing and a non-viable tumor thrombus, and this patient may be considered for transplantation. That is subject to trials, and maybe we will learn about that more. So these are the factors which probably are important in getting decent results in portal vein tumor thrombosis. Untreated, we know that the median survival is 3 to 6 months. With treatment, if we are able to extend it to 18 months or 20 months, and if luck be on our side, or if we go deeper and are able to downstage them to transplant or resection, unlikely resection but transplant, probably we will be there. Thank you.
Thank you, Dr. Kulkarni.
Yes, questions? So now we are relying more on the lyrides. Okay, so when this all began, RECIST has a problem that we look at the size. In radioembolization, the size doesn't change. What we look at is necrosis. So we have the EASL score, where we look at percentage necrosis, where 100% necrosis and non-enhancement is complete response. Less than that is partial response, stable disease, and no response or progressive disease, according to what we have. In the lyrads, we have viable tumor, non-viable tumor, or equivocal categories. Most often, after radioembolization, we will see persistent internal enhancement up to 6 months, and that is because of the effect of radiation. And these are most often classified as equivocal up to 6 months, and then we start seeing shrinkage in size and non-enhancement.
Have you ever looked at doing a regard with locally available isotopes?
Isotopes, radioisotopes, locally available.
Might be that
The radio label, the lipiodol, rhenium, they are not available much. Lipiodol is most of the data is with rhenium lipiodol, but the generator is not available. Yeah, P32, we have no experience with that. Sir, actually, we have such a robust system with this Y90. I understand.
Anirudh,
Yes.
so as Kaushal rightly said that you control the flow of patient, would you send any patient to SBRT with TARE taking care of everything?
No, I am
Okay,
on his
Kaustav.
side. I am on his side because I am a fan of radiation, but I am a fan of intra-arterial radiation. So we can so precisely irradiate only the tumor and surrounding 1 centimeter rim that I believe that this is the way to go. But I am a fan of
think
radiation.
It's very unfair. Kaustav did a very excellent presentation, and as I told Kaustav, we should have protested. And as I told him in his meeting, surgery, after that is SPRT, after that maybe, may not be.
So I think
And I don't know why it took such a long time for SPRT to come there. The last time I spoke about SPRTs in your meeting, some 10 years back in one of those meetings. Kaustav, after excellent presentation, I thought it was evident.
So, see, SBRT has a 3-dimensional mapping and dosimetric system which TARE does not have. The plus point of TARE is it delivers a very high dose through the artery and a circular rim. Tumors are not always circular. SBRT. So both the systems have their pluses.
No, I will stop you there for a second. All patients who undergo TARE, we keep a catheter in the hepatic artery, do a CT scan. Okay, so we have volumetric evaluation of these patients.
Dosimetry
It
is
is
not
absolutely 3D volumetry. So it is not that we don't have 3D volumetry.
Dosimetry is not there. Tumor dosimetry is not
No,
there.
we have there. We have reached there. So for patients without portal vein tumor thrombosis, 390 is our threshold dose for getting good result, and for with portal vein it is 205.
The moment you are injecting anything, it's always heterogeneous. It's never uniform. If you read most of the papers and even mathematical modeling for intra-arterial embolization, they are always heterogeneous and there is always a range. When you speak of 200 odd gray, and it looks as if it is all homogeneous ball of
No, it is of course it is
happiness
average.
sitting there. It's not there.
It is average.
And
It's average.
It ranges from
Yes.
8, maybe 20, whatever, and it's biologically different because it's over a period of time. It's a cumulative dose. So you cannot create a false equivalence between SPRT 200 gray vis-a-vis this one. That's a false equivalence.
So actually, just we've seen excellent results with TARE. We've seen some good results with SBRT. I don't think it is. I think both are good systems, and I think time will tell us. But we've had patients where with SBRT with TARE we've been able to downsize them. As Amit also said, we've had patients where they've been downsized with
I'm not saying it's
with TARE
ineffective.
to transplant, with TARE to resection. So it is.
Kaustav was already presented, equivalence of outcome, right? I mean, she showed equivalence.
Yeah, so I think the jury is out. I don't think we can, it's very difficult to say that one is good or, I think there's merit in all systems. So I think we leave it at that, sir.
No, we'll leave it at that.
As a surgeon, when it is not resectable, not transplant, not possible, what would you do?
I understand jury is out. That's the reason that's why we are discussing, right? Having said that, it's very simple. If you want to manage this disease, small enough, go to Ganesh. A little bigger, not operable, not problem, go to Kaustav. Is it okay? If still you have a problem, send it to him.
Great, sir. I think that summarizes it very well. And then, of course,
Thank you.
Excellent. Great.
Thank you,
talk,
Dr.
Anirudh.
Kulkarni. Next is the case-based panel discussion to be moderated by Dr. Ganesh Nagarajan. Dr. Nagarajan is a director, HPB surgery and GI oncology at Nanavati Max Super Specialty Hospital. I'll also invite all the panelists. Dr. Rajesh Shinde, sir is consultant surgical oncologist, HPB and GI oncology, Apollo Hospitals, Navi Mumbai. Dr. Anirudh Kulkarni, director, vascular and interventional radiologist, Nanavati Max Super Specialty Hospital, Mumbai. Dr. Viral Patrawala, sir is gastroenterologist and hepatologist from LH Hiranandani Hospital. Dr. Nagraj, chief radiation oncologist at Nanavati Max Super Specialty Hospital. And Dr. Vashisht Maniyar, consultant medical oncologist, Mumbai Oncocare, Ghatkopar and Kemps Corner.
So I think Vasisht and Viral should join us shortly, or are they outside? So, let's quickly go through. We've had some great talks and we've had some exciting debates. So let's look at real world scenarios. Let's see how, as a group sitting here, and we'll be very happy to have inputs from everybody. And 65-year-old gentleman, long-standing diabetic. Vasisht, I think we'll get you on the panel, please. No other comorbidities, long-standing diabetes, a little obese, USG showing, you had a ultrasound incidentally showing a large SOL in the right lobe of liver. Billy enzymes, PTINR was all normal, but the AG ratio was 0.95. That was the only hint that his liver may be a little compromised. Platelet count was a little bit on the lower side, 1.5 lakhs, Hep B, Hep C negative, AFP normal. That's the tumor on the triphasic scan. Do you have a pointer here? Yeah. So you can see a large tumor there. Yeah. So we have the, you can see a large tumor in the right lobe. Right vein was not visible at all. Middle vein was completely skirting along the mass. The left vein was free. So let's quickly get to Anirudh. So practical discussions here. MRI versus CT. How often and when would you insist on an MRI rather than a
So our workhorse for HCC diagnosis is CT, but there is an increasing role for the use of MRI because for the large tumor CT will show us very clearly and very well, but small lesions may be completely missed with CT. So if we are looking at diagnosis, MRI probably is the a better modality. But when we want to look at the resectability and relation of this lesion with the veins, the arterial supply, CT will be the mainstay. For example, if we have a clearly operable or resectable lesion on the right, in the right lobe of the liver, we still want to do an MRI because on CT we may miss out lesions in the left lobe which may alter our surgical plan, may ask us to do an intraoperative ultrasound, or patient may completely become a non-surgical candidate. So there is a role for both. For diagnosis, MRI probably will be the mainstay and CT for resectability assessment.
Rajesh, would you always insist on an MR?
No, sir. No, sir. No, I would only go with CT scan, particularly in this case where there is a reasonably large mass in the right lobe. I would judiciously use MR when there is a ambiguity or inconclusive CT scan, or if I want to differentiate a tumor thrombus from blunt thrombus, or I have to follow up small nodules like less than 1 centimeter or 2 centimeter particularly in a cirrhotic liver.
Fair enough. So I think well summarized by both of you. Rajesh, continuing with you, how often would you ask for a PET in an HCC?
So if I have a good quality triphasic CT scan of the chest, abdomen and pelvis, I will never ask for a PET scan. Because PET or the FDG uptake is not very often seen in HCCs. It is only seen in approximately 40% of the tumors, and the bone mets are also not very common. So if we have a good quality triphysics scan, we will not go for a PET scan.
Right. I think resectability assessment, you want to summarize what all you look for when you assess for resectability.
Yeah. So I would first see where is the tumor located, size of the tumor, relation of the tumor with the portal vein, hepatic veins, and the condition of the remaining liver. That will give me a broad idea whether how much will be the FLR and all.
Right. So we'll come to that, and I think
course, extra hepatic disease also.
Of course. I think Dr. Patrawala isn't there. Amit, you want to take this? As you said in your talk, increasingly you're seeing more and more of NASH, NAFL patients coming up with HCCs. I think we already discussed about screening protocols, so I wouldn't dwell too much. So if we get the message right, in patients with advanced fibrosis, you would treat them like your Hep B and Hep C patients, and you would get them screened for with a 6-monthly ultrasound AFP?
Yes. So any patient with advanced fibrosis, cirrhosis should be on a surveillance protocol every 6 months with an ultrasound and alpha-fetoprotein
the quick question to you is whether, and maybe Anirudh also can tell us, that usually these patients are obese, they are, how easy or difficult is it? Is ultrasound as good a screening modality in, these metabolic syndrome patients as they would be for Hep B or Hep C, or is there a difference?
If I see a lesion on the background of fatty liver, I can be reasonably sure. But in these patients, I am not sure I am going to see every nook and corner of the liver. So we may definitely miss lesions with ultrasound, even though that is a widely available and easily available modality. I think MRI is much better and for diagnosis and picking up lesions.
I agree. So if there is a doubt, see, like we can't put them on an MRI surveillance as of now because of the cost, and most of these guidelines come from Western countries where it's insurance which would be paying. But if there is a doubt, especially if the alpha-fetoprotein is going up, then definitely. So ultrasound is what has been described by societies, but in select patients, we need to go for an MR or
because we often have this situation where you see a lesion on the MRI, but when we do an ultrasound, retrospectively also we are not able to see. So we are definitely going to miss lesions.
MR is far superior to ultrasound in picking up the lesions, yes, but as a surveillance protocol, it has to be cost effective.
Fair enough. But I think that's just one of the messages is that it's not as easy to pick up lesions in a fatty liver as it would be. Yes, Vasis.
Small question.
What about contrast-enhanced ultrasounds?
Again, very difficult. Very difficult. If it is a lesion in the center of the liver where surrounded by liver parenchyma ulcers and we are seeing it, then we hardly ever need contrast if there is a visible lesion. But we so often miss lesions even in retrospect.
So we'll come back to this case. So we did a volumetry as Rajesh suggested, and the FLR, the future liver imminent as the FLR was around 26%. Long-standing diabetic, fatty liver, 26% FLR. Rajesh.
Technically, 26% is sufficient for a right hepatectomy, but this will be most likely a MHV sacrificing. I have also done in initial time right upfront surgeries like in this case, but now I would always go for some sort of a downstaging with TESS or at least a portal vein embolization before embarking on the upfront surgery.
Right. So when we have a fatty liver or when we have a background of long-standing diabetes, NASH, NAFL, usually these patients with fibrosis, with steatohepatitis often behave like cirrhotics, and while 25 to 30% is good enough a remaining volume for a normal liver, when we have these patients, we often find that when we've operated them up front, we found that they've had a stormy post-op course, and that's why we've realized that getting an increased volume on the FLR is very useful. And in this case, this is what exactly we did. We did a TACE followed by a portal vein embolization. Anirudh, you want to explain why we do a TACE followed by a PVE, not just a PVE directly?
So, when we do a portal vein embolization to the right lobe, the unhindered arterial flow will result in excessive tumor growth in the intervening period. So that is why we want to do both the things. And also, when we do it has been observed that a combination of TACE plus PVE probably results in better hypertrophy of the FLR.
So, and previously we used to wait for a gap of at least 3 to 4 weeks between the TACE and PV, but recently few cases we have done the TACE, and then within a week or 10 days, once we know that the LFTs are normal, the enzymes have come down, we immediately go ahead with the portal vein embolization. And after that, we wait for a period of at least 5 to 6 weeks to see the hypertrophy. And sure enough, we had an around from 26 we got to 34. That's a reasonable outcome, because normally anything less than 6% is a poor outcome for a portal vein embolization, indicating a poor regenerative capacity of the liver. Anything above 10% is excellent. Between 6 and 10 is fair. And we went ahead and resected this patient for a right hepatectomy with MHV. Now, histopath was well differentiated HCC. Margins were negative but close, around 2 millimeters. Now, Vasisht, now this is where we need answers. Of course, these patients, we have resected them, the patient is fine. Would you want to, or would you think, I know presently there's no evidence, but would there be a role for, now we've talked about so many agents, should we give an adjuvant treatment in HCC?
So the current answer is no, but like in a lot of similar malignancies, for example in RCC as well, for the longest period of time, or for melanoma, the answer was an obvious no. And now we are moving into that grey zone where for a select few we have evidence to believe that immunotherapy may be used as an adjuvant arm in those patients. But as of now, on 2022 December, a beautiful Saturday night, the answer remains no.
So, and I think this is, and probably maybe in 2023 December when we meet again, we may have a different answer from you.
We so sincerely hope. Then you will see more medical oncologists sitting on the MDT of HCC.
Please don't forget to invite us.
For sure, for sure.
So I think because this is one of the problems that we face. Yeah.
So I was happening to listen to a discussion on entity, similar entity done with, I think, on the Oncolive portal. So there they had a similar 5 centimeter mass which was dissected, and they saw that in the mass there were a lot of vascular invasions within the mass, and they saw that this could be a high risk factor for, and they used lenvatinib in those patients for 6 months. So that is some evidence which they are trying to foray in the future. Probably we may see that.
Yeah, so I think slowly we will move, like all other tumors. I mean, we would not hesitate to give an adjuvant treatment for so many other tumors. It's become standard of care, and probably someday, because many of these patients after surgery, there is a possibility that they are likely to recur. Almost 50 to 60% of patients will have recurrence in the future, and especially because all these livers are compromised livers, and that is the whole rationale whether or not we should think of.
Absolutely. A small point there is, let's not underestimate the toxicities of these drugs, and you do not want a TKI causing a liver dysfunction before you get a recurrence. So, and how long will you give? Will it give for 3 months, 6 months till progression? So yes, we need enough data and answers before it's like all fitter, where somewhere all of us feel that this patient is going to recur, but still we need some evidence to suggest that yes, we can use this drug.
With the number of centers MOC has, I think it's time for you all to do a multi-center trial.
Very soon.
Can I ask something?
Nanavati will be a part of the trial for sure.
Sure.
So suppose this was not 2 millimeter and that report would have been focal tumor seen on the margins. What would have been the strategy then?
Sir is itching to radiate.
All yours.
Not now, nothing at all. No, no adjuvant.
Yes, Ashish.
I don't think there's evidence for all of
Yes, there isn't.
As a part of the downstaging or a bridge therapy, would you always do a PV embolization along with TACE, or it's an optional thing?
No, the PV is because we had a little smaller volume.
Yeah, but typically if your the tumor-free volume is good, then you would not
Yes,
do PV.
if we have a good volume, there's no need for a TACE or a portal vein embolization. Then we go for surgery upfront.
Correct.
But here, because we had a compromised volume, because the most dreaded situation for a hepatic surgeon is when you have resected and you have the bilirubin is mounting post-operatively, you cannot do anything about it. Neither can Amit, and you just have to wait and pray that it settles down.
Sure.
So I think that is that's the disaster we are all worried about, and liver insufficiency is something that you really can't do anything about, and that's the reason we are always a little bit worried about remnant volume. We'll quickly move to the next one. 65-year-old gentleman, upper abdominal pain, Hep B positive. CT showed a large mass with 2 other lesions in the left lobe. I'll just that's the lesion. Right portal vein was thrombosed, LFT and INR normal, but the AFP was 14,000. So that's the mass. Right portal vein thrombosed, and the left, I'm not sure these scans are, those were the small lesions on the left side. So, Rajesh?
I would send the patient to either Vibha.
So you have to choose whom now, after all of today's discussions. all 3 of them are waiting to hear from you.
Maybe sir can do more justice.
This is a huge mass. So a size ahead of 8 centimeters with main portal vein thrombosis is a poor prognostic factor for radioembolization. The chances of decompensation are high. Chances of getting a good response are very low. But if the general condition of the patient is good, we might give it a try, because other options are fairly limited in this patient. So maybe this is a decent case for radioembolization.
Would you do a metastatic workup before you do an attempt or consider a tear, considering that the AFP is 14,000?
Yes, and almost as a protocol, we do metastatic workup for these patients, especially because there is a very high cost involved in this procedure. We don't want a situation where we do a procedure worth 12-14 lakhs and on the first follow-up the patient has mets everywhere. So that's why we tend to do.
I think we'll be very surprised if the metastatic workup is negative for an AFP of 14,000.
Right. So in this patient, the metastatic workup was negative. Now, would you, patient comes to you first, Vasisht. So would you look at Atezo-Bev? Would you send the patient to Anirudh, or a combination of both?
So a lot of uncommon situations here. First, a patient coming to us in an unoperated, unteared, untased HCC. I think standard guidelines at this point of time, with an AFP of 14,000, even if the PET, or CT, PET is not a great modality anyways. It's very specific though for the ones who are positive. It's a matter of time that you will see systemic metastasis when you have such a high tumor, secreting tumor burden. So I would want to believe systemic therapy first, Atezo-Bev, assuming there are no large impending variceal bleeds. So I would get an endoscopy done before I start these patients on Bev-based therapies. And there are no other contraindications for using this combination. Atezo-Bev would be my first choice. And if this patient has a very good response where the thrombus does become bland in the coming months, it might not be a bad idea to add some local therapy like a TACE or TARE.
Sir, would radiation be an option? Would you look at SBRT for this patient upfront?
No, not SBRT for this patient, but then because of course there are multifocal disease, and then even though there was no metastasis, perhaps no. I did something like this for a very advanced metastatic liver, what we call as a spatially fractionated radiotherapy. Probably a good palliative procedure, but not here. I just thought I would share that.
Right. So I think fair enough. Let's quickly go on to to the next one, and 60-year-old patient, vague abdominal pain, again pretty much normal liver functions. Hep B, Hep C was negative. Non-diabetic, excellent general condition. AFP was normal. CA19-9 was 13,300. That's the tumor there. Large left lobe tumor involving middle and left veins. Right vein is completely indented, going on to the opposite side, as you can see here. This is the PET, very brilliantly enhancing lesion on the PET. Surprisingly, no other metastasis anywhere on the PET. So Vasisht, we'll start with you. So and then go on to Rajesh. So what would be your approach in this case?
I would love to have a histopathological understanding of the disease. It's most likely an intrahepatic cholangiocarcinoma or a mixed tumor.
Yes, so on biopsy we did find it to be a mixed tumor. It was mixed IHC, HCC. The CA19-9 was significantly high. Rajesh, would you embark on a brave resection, vascular reconstruction, the right hepatic vein?
I don't think this is a case for an upfront surgery, at least, even if it is a non-metastatic, considering the high CA19-9 and the locally advanced nature. I think we should try some form of a downstaging.
So what kind of downstaging would you prefer? Would you want radioembolization? Would you want chemotherapy? Both. Or a combination of both? Anirudh, how feasible is it? What is your experience with TARE for intrahepatic or mixed tumors? Intrahepatic cholangios or mixed tumors?
Technically it is feasible, but the results are not as great as HCC, size matched and similar looking HCCs, because the cholangiocarcinomas are not that vascular. Because here in radioembolization we are totally relying on the hypervascularity concept. As vascular a lesion is, the better deposition of the radioembolic and better results. But we can look at some downstaging with radioembolization.
So, Vasisht, would you prefer to give some chemo first, and then if we are encouraged by a response, would you send it to Anirudh, or would you want it the other way around?
So I think this is a perfect case for an MDT. The reason being that if the hepatic surgeon believes that downstaging is going to help and lead to a surgical outcome, then we would want to be aggressive and give a triple drug therapy. There is rationality to use cisplatinum, gemcitabine and nab-paclitaxel, all three. If surgery is never going to be possible, then in a palliative case setting, I wouldn't want to justify using a triple drug combination. We would typically use a combination of platinum and gemcitabine. If there is a very good response to systemic therapy post 3 cycles, then I don't know the data, but there may be a rationale of some local consolidation, and whether it's going to be a TACE, TARE or SBRT if the lesion becomes half in size is for all of us to imagine.
Right. Amit, you had something to say? No. So usually in such cases, I think our preference has always been to try and probably systemic therapy works best initially. So rather than spending getting the patient to spend 15 lakhs and then have metastasis in few months, I think if test them with systemic therapy, if we have some response, a chemo responsive disease is the only chance that we may end up with something else in this patient. So I think 2 or 3 cycles of chemo, if we have some response, then maybe liver directed therapy would be our thought process, but any differences we'll be happy to discuss. Ashish.
So we can also subsequently with the TOPAZ studies, 20% patients had exactly the disease profile like this, and the responses have been phenomenal and durable. So we could probably also think of consideration of cisplatin, gemcitabine and drug called as durvalumab, which is wherein 20% patients in TOPAZ had a locally advanced inoperable disease, and some of them ended up going for a further resection and local therapy. Maybe that could be also, but again, cisplatin, gemcitabine remains the standard of care.
So though it's a locally very aggressive disease, if we have a great response, some small possibility that if you have a great response, maybe a left extended with a vascular reconstruction could be possible. So yes, probably aggressive chemo, maybe followed by aggressive liver-directed therapy, and then test the tumor biology and then see if we can end up with something. So I think we've discussed most of some of the scenarios here, and I think we've got another panel, so we'll get a few other 2-3 other cases and see where that takes us. Thanks.
I will invite the next set of panelists. Dr. Ajay Kolse, Consultant Radiation Oncologist at Holy Spirit Hospital. Dr. Dolly Doshi, Consultant Vascular and Intervention Radiologist, Mumbai. Dr. Mehul Choksi, Consultant Intervention Gastroenterology, Nanavati Hospital, Mumbai. Dr. Udeep Maheshwari, Consultant Medical Oncologist from Mumbai Oncocare. Dr. Devendra Pal, again Consultant Medical Oncologist from MOC Panvel.
So, Amit, why don't you join us, because for this case, because we can talk about transplant and Anurag couldn't make it.
I would also invite Dr. Vivek Sukumar.
Is there a surgeon? Yeah, come. Dr. Vivek is a surgeon at...
Dr. Sukumar is surgical oncologist from SSO.
Okay, hi, come. So this is a 39-year-old male young chap, hepatitis B positive, on entecavir. Ultrasound, grossly nodular cirrhotic liver, 2 centimeter lesion in the right lobe. AFP2, bilirubin of 2.1, platelets 94,000, AG ratio reversed. Otherwise, no ascites, mild varices, INR is fairly okay, one just bordering on. So that's the lesion. You can see a single, this is arterial enhancement, venous washout, 2 centimeter lesion, segment 6. Known cirrhotic, known hepatitis B positive. So, Mehul, let's, so I think just for the benefit of non-gastroenterologists and everybody else, maybe quickly run through the screening protocols in Hep B and Hep C. Amit has alluded to it in his talk, but I think just a quick recap for everyone.
So hepatitis, you're talking about hepatitis B cirrhotic or only hepatitis B?
Maybe across you can cover.
Hepatitis B patient who is on therapy every 6 monthly LFT and alpha fetoprotein with the ultrasound of the liver, and yearly DNA quantitative on therapy. And for hepatitis C, so now we have basically treatment of 12 weeks to 24 weeks based on the RNA and the cirrhosis, and they can be followed then once a year with LFT and USG, and HCV RNA maybe once a year.
Right. So, and for all your cirrhotics, if you're Hep C cirrhotics, you would continue screening, as Amit mentioned.
Yes, definitely.
Absolutely. So, Dr. Vivek, in this case, are you happy with the CT single lesion, 2 centimeters enhancement washout, or would you want an MRI?
Yes, I would like an MRI in this particular case because he has a compromised liver, and he also, there is a probability that he would have multiple lesions which we need to rule out to plan the further treatment, and also would like to correlate with other factors like the AFP and further.
Right. So incidentally his AFP was normal, and maybe both Amit and Mehul can tell us, would you also do a PIVCA on this patient, Amit, at your center?
So yes, we do PIVCA as a part of research also for all our patients. We are maintaining the data, and we have found that it's useful in conditions where there is a tumor, but if AFP is normal, PIVCA may help. So as a routine, it is not required for everyone. We do it as a part of our protocol for all patients. But if there is a lesion which is unequivocal, and if AFP is normal, PIVCA is high, again the index of suspicion would be high. So PIVCA does add value when there is an ambiguity about the diagnosis.
Right.
And at times about the tumor burden also. So if there is a large lesion where AFP is, if it's an AFP non-secreting, Again, a very high DCP or PIVCA would tell us that it is a biological aggressive tumor. So in ambiguous cases, either for diagnosis or for prognosis, PIVCA may add value, but as a routine, not required.
Right. So, Dr. Vivek, would you consider this patient for a resection? It's a very small 2 centimeter peripheral tumor, or would you want your interventional radiologist to ablate it, or would you want to send it across for a transplant?
Actually, this is a decision for the MDT because it's a young patient who has a poor liver function, along with the criteria which is meeting of transplant as well as for an ablation. So I think an MDT decision would be appropriate.
So that's what we are doing here. So let's
speak to the interventional radiologist if you need.
So Dr. Dolly, right?
So as far as the ablation here is considered, yes, the patient can be a perfect candidate because going to the lesion is not a problem. The worry most of the times is about the heat sink effect if the blood vessels are in vicinity. But we also have microwave ablation which has similar effects like the RFA. So it will not have the heat sink effect. Lesions less than 3 centimeters tend to do really well, and they are as good as undergoing a resection. So if resection is not the possibility, then most of the times we do end up taking up such cases.
So Amit, would you directly transplant this patient at Global?
So child A cirrhotic with portal hypertension with a 2 centimeter lesion, I think what we would do is we would send a patient for ablation, considering that there is portal hypertension, platelets were low, small varices, so ablation, but we would also list him for a cadaveric transplant. The reason being is we often do not give importance to hepatitis B. In fact, Ganesh, at Bujon, if you remember, a hepatitis B related etiology they would probably consider a transplant in this patient. The reason is that hepatitis B is an oncopathic virus, and a person who has had one tumor in a setting of cirrhosis, there is a very high likelihood that he would have recurrence, and the recurrence in hepatitis B can be multicentric, which may not be transplantable later on. So I would probably not transplant upfront. I would send for ablation, but I would also list for cadaveric and keep a proper surveillance. Had it been more than 3 centimeters, I would have probably considered upfront transplant. Within Milan criteria, cirrhotic patient, I would have considered transplant.
So I think fair enough. I think so ablate, but consider transplant soon. Now, Dr. Vivek, if the bilirubin and platelets, if suppose this was a completely, of course, a cirrhotic, but completely normal LFTs, normal platelet count, would you consider a resection or would you ablate?
I would still ablate first and then look for his response, see how he's doing on follow-up, and then plan for resection if there is.
Right. So the message being that, in fact, there have been many trials, randomized trials, looking and comparing RF versus surgery for even in cirrhotic patients. So I think overall the consensus has been that if you have lesions which are 2 centimeters and lesser, the results have been absolutely similar, and I think ablation is the way to go. However, tumors, when they looked at the subgroup between 2 and 3 centimeters, they found that those are the ones, while the guidelines usually suggest anything less than 3 centimeters, as you mentioned, but when they looked at the subgroup of 2 to 3 centimeters, they found a significantly higher incidence of recurrences in the ablation group as compared to surgery, and that's where the surgery scored. So nowadays in most of, say, the Hong Kong group which did a randomized trial, their protocols are now that if it's more than 2 centimeters, then resection is probably has an edge over ablation. Let's look at another case, 78-year-old gentleman, ECOG 1, Parkinson's, but otherwise fairly well preserved, long-standing diabetic. Again, viral markers are negative, bilirubin normal, AG ratio but reversed, INR 1.2, platelet count a little borderline, 1.1 lakhs. AFP is 430. Now, this is the lesion. You can see maybe around 6 to 7 centimeter lesion here in the right lobe, arterial enhancement, venous washout, no other tumor elsewhere. Not a very large left lobe, compromised, old gentleman. Vivek, any plans to operate?
No, sir.
So what would you-
Probably because the left lobe is not it doesn't look like the size is smaller in size, large, more than 5 centimeter lesion, along with other comorbidities and age of 78, wouldn't go for an upfront surgery.
So what would you recommend for this patient?
So we would like to first send to the interventional radiologist and try to embolize the right side, see if there's hypertrophy, and then reassess.
So, Dr. Dolly, would you prefer a TACE or a tear in this patient?
So both of them will have very good results. Considering the size of the lesion, TACE also should do fine. DEB TACE also will do well in such cases. If the patient is affordable, of course, then tear too can be done. All of them will have good results. But again, affordability is a major challenge in our country. So if the patient is not very affordable, then we'll still stick to at least TACE, followed by portal vein embolization to hypertrophy the other side of the liver.
Ajay, would you want to go for...
With SBRT, affordability will not be a problem, and definitely it will take care of the lesion. I feel I would go with SBRT.
So any comparisons between SBRT and TACE in such a case?
Both, there are upcoming trials, as Dr. Kaustav had shown. But
or you want
limited.
to combine the two, Kaustav?
So Ganesh, can I just add, because we had reviewed this in our journal club just 2 months back, there was a randomized control trial as a downstaging protocol SBRT versus TACE, published from Hong Kong, which was published in Hepatology Journal, where they used, it's a randomized control trial SBRT versus TACE, and they found on the explant, when the patients were finally transplanted, that the control of tumor or the complete control of the tumor was much better with SBRT than with TACE, and the side effects was. So I think SBRT is a evolving modality. I think it still has a growing role, and this was an RCT which was very well done, published in Hepatology, which is an index journal. So of course that was as a downstaging, but at least it was a proof of concept that SBRT works as well, if not inferior, if not superior to TACE.
Dr. Nagaraj and Dr. Kaustav are taking you out for a single malt after this.
Say it's evolving. It has been there for decades.
Yeah.
Why do you call it evolving? For God's sake, it is there.
Only thing is, patient don't come to us, so we have to wait.
The whole world bothers about total dose to liver, 15-gray dose to 700 cc, and 1/3 liver, RILD, anacretic, everything. And with tear, which is 3 times the more dose, agreed it is through a vessel, no one is talking about the total liver dose, point dose to the liver, the RILD is there or not. I mean, how is AERB allowing that? I don't know.
Fair enough. So I think we come to, this is another interesting case, and I think Muzammil, you can also give your inputs. This is a patient that we had treated at Hinduja almost 3-4 years back, when of course the available agents were a little different. But let's look at this 60-year-old, CEO of an MNC, meaning that he could afford everything that you could throw at him. Hep C positive, taken treatment, cirrhotic, child A, fairly well compensated, bilirubin 1.9, INR 1.2, platelets 85,000. Predominantly a very diffuse kind of lesion in the right lobe with a couple of satellite lesions around it with a portal vein thrombus. Some small indeterminate opacities in the chest, not sure whether that was metastatic, indeterminate, very small to characterize, no other metastasis. I think his AFP, if I remember right, was not too high, maybe around less than 1,000. So this patient, we'll quickly go on to the medical oncology part of the discussion because that's interesting. So he underwent, because it was a predominantly localized disease, largely unmetastatic except for some very small lung nodules which we couldn't really make out. TARE was offered to him, and he responded very well to the tear. As you can see, is almost a complete response to the tear, complete necrosis on the easel criteria, as Anirudh mentioned. Now, because there were doubtful lesions in the lung, we were not sure of, he was put on sorafenib. This image is 4 months post-tear. Now, he developed severe mucositis with hand-foot syndrome with sorafenib. So, in such a situation, what would both of you, each one of you could give your opinions.
Hand-foot syndrome is a well-known complication of sorafenib, and with time, all medical oncologists have learned.
I think your mic is. It's on? Yeah.
With time, we all medical oncologists have learned how to manage hand-foot syndrome. So we have to grade hand-foot syndrome, and if it is in severe cases in grade 3, we have to discontinue the therapy for some time, and we can re-challenge after hand-foot syndrome has resolved. So unless it is stage 4, then we should not be re-challenging. If it is like grade 3, then we can re-challenge it, or we can after when we start again, we start at the lower doses of sorafenib. And when we stop sorafenib, then we have to give local treatment for hand-foot syndrome. So that's we can re-challenge always after giving local therapy.
Okay. So Dr. Udip, would you what would you start? What would be your preference once you stop the sorafenib?
So is it 4 years back or right
Today.
now?
Today.
So today I I would have started lenvatinib first of all, but since he started on sorafenib as of today, and he is not tolerating the dose well, then there's data enough that we shift on lenvatinib or the newer immunotherapy molecules if it was first line prior. So I think he's been started on a TKI, so might as well continue on a TKI and change over to lenvatinib.
So Ashish, Vasisht.
So I think second line, you will be looking at kind of second line or a first line, but intolerant to TKI. So then we have got, as we've just discussed, we have IO-based therapy as an option where we have got 3 drugs, pembrolizumab, nivolumab, and durvalumab being studied. And in the TKI, we have got cabozantinib, lenvatinib, and in anti-VEGF purely, we have got regorafenib. So we've got plethora of treatment options. I think the concern here would be that since he has developed sorafenib-induced hand-foot syndrome, I have a concern about tolerance to his second-line TKI. So maybe a switch to an immunotherapy-based regimen could be a reasonable option in this situation.
So I think this one was started on nivolumab, and he tolerated nivolumab quite well. But I think 8 to 10 months subsequently he developed lung lesions. Vasisht, you want to comment, and then we'll come back to Udip and Dr.
So I was strongly contemplating the fact that in these rather hopeless situations, it's definitely worth getting a next generation sequencing done. NTRK mutations, RET mutations are known to happen, including PI3CK mutations are known to happen in metastatic HCCs, and now we have targetable drugs for those.
This patient we have done the NGS in the second, so everything was negative, no disease. And just one comment on what Ashish said, that if someone is intolerant to sorafenib, don't re-challenge with at least regorafenib. Other TKIs still can be thought of, but as a understanding, maybe immunotherapy was a better option. That time we had, it is some 5-year-old case actually. Yeah, so nivolumab beta was there, we were excited that time. So we put him on nivolumab, done well for almost 14, 13 cycles he took, I'm not remembering, and then progress. So that is where we are.
So Dr. Maheshwari, let me ask you, presently tell us what is the status of nivolumab. Is it given up? Is it still an option?
So second line, definitely it's an option. First line, obviously we have good data with the strides. The strides data is also fantastic. The stride regimen of durvalumab, tremelimumab is very good, and even we have that data of atezolizumab, which is a long proven this. So first line, definitely these. Nivolumab can be used as a second line option. I've used in a couple of patients. They do well.
Also, Ganesh, nivolumab is the only one where it's been used in childhood B. So if you see critically the NCCN guideline discussion, it really mentioned that nivolumab has got a space in child book B, otherwise in the first line it's withdrawn. The FDA, subsequent to the checkmate 040 data, because the delta was not big, so the FDA approval was withdrawn. But it mentioned that for child book B, nivolumab still has a space. So somebody who's got a little bad liver functions, probably you could use that.
Right. In today's, if fast forward this case to today's situation, would you consider at this point, would you consider atezo-bev?
Yeah, this patient must have appeared presented now because he's a F-ODing patient and is probably metastatic also, lung nodules are there. He's in child books A, so he's an ideal candidate for bev-atezo.
So in this patient at that time, Muzammil, maybe you can just...
Yeah, so that time there was not enough data, but a lot of papers already going in press about combination of immunotherapy with a VEGF inhibitor, now which is the standard of care. This is 5 years back, just to make the scenario. So we added lenvatinib at, of course, a lower dose. We started, and then he tolerated quite well initially, but then Ganesh will take over. He developed some complications.
So 5 months later, after the combination of lenva and nivolumab, he had an adrenal lesion, and that bled, and he came with a huge retroperitoneal periadrenal perinephric hematoma with a drop in hemoglobin, and we did a CT angio. There was no bleeder, it got conserved, but he had a big bleed, but it was self-limiting. Does lenvatinib, is lenvatinib the offending agent here? Could that have caused the bleed?
Doesn't look like.
Less likely, sir. Well, we know that BEV is known to cause such bleeds, but lenvatinib data of it does have vascular this, but then there is no data that it's a contraindication for a bleeding event or something like that. So I don't think.
Muzammil, you want to comment, or Ashish?
Yeah, so there's a lot of data actually. This lenvatinib is not an innocuous drug because I have used at various dosing combinations, right, from 24 milligram per day. So I have seen horrible bleeds in few patients. So it's not a safe drug as far as bleeding is concerned. In this case, there was no other identifiable cause because liver function was still well maintained. So we can't attribute anything else for such a large bleed. Okay, so possibly it was lenvatinib induced is what we believe that time. And of course, it was not possible to re-challenge with such a massive bleed. We stopped lenvatinib there. Ashish?
I think just alluding to, not sure whether etiology is lenvatinib, but nonetheless, to my colleagues a question, do you really use 15 mg per kg of bevacizumab? I don't. I at best use 10 mg per kg because the dose recommended in Embrace 150 was 15 mg per kg. And I've seen, since I'm in a PI in a couple of trials where you're using 15 mg per kg, we have had significant side effects causing treatment discontinuations. For me, 10 mg per kg is a hard stop. What was this?
So use 15 mg in a few patients, and honestly, so very well preserved patients, no varices or grade 1. I have used in couple of SCCs, used a lot in cervical cancers, 15 milligrams. So well tolerated drug overall, but once occasionally you will find some patient who has hypertension and other side effects. Yeah, no.
So what I was alluding to is that there is no contraindication as as it is there for BEV. There is a contraindication for it. It is not there for lenvatinib, but in this case definitely there is nothing else that you could have.
So now you would probably, fair enough. So now lenvatinib is stopped. Now in this situation right now, what would you do next?
So we've already used nivolumab, we've used lenvatinib, we've consumed that, and now I think so all of the agents that we know that are going to work here are going to work on the vascular system, right? So even cabozantinib will work on the vascular system. So only challenge is whether we can use cabozantinib. I don't know.
We'll use Folfox.
Yes. Chemotherapy.
Folfox was actually, to be very honest, Folfox was compared with an inferior regimen called a single agent doxorubicin, and still it gave response rates of 32%. So and then it's still a category 2B recommendation in a patients with such kind of situation. Your IO is not possible, TKI is not possible. You can still use conventional Folfox for this patient.
obviously, so I agree that the chemotherapy role is still there in liver, that Folfox regimen. Also, there is that data of immunotherapy wherein we boost the immunotherapy with a CTLA4 inhibitor or a durvalumab plus the booster of tremelimumab that they give. Usually, they increase the effector cells, and that can also work. Post nivolumab, sometimes it can work. That is something, obviously there is no data to it, but then you can use that as an option. Cabozantinib has a slightly different mechanism of action than Lenva and sorafenib. That can also be tried in low dose, can start from 40 milligram OD. So those are two options that I
Dr.
feel.
Pal, you want to
Actually, cabozantinib is is in recommendation of the third line therapy also, and the data is there to use in third line. So nothing stops us, even after failure of other TKIs, cabozantinib can be used in third line.
So Muzammil, I think that's what you did.
Yeah, so that was all imported that time because everything was very costly, but he could afford, including Lenva was imported with a 17 lakh per month of dosing. So we gave him Cabo. On Cabo, he pulled for 5 or 6 months. Then he called
I think
out the
another
day.
8 months later, he came back with spine mets.
Yeah.
And then the radiation oncologist took over. Right. So I think pretty much covered as much as we could, all types of scenarios, various cases, interesting discussions, and thanks to all the panelists. Thank you.
Thank you all of you. We are in the final segment of our program. Coming up is the debate on role of systemic therapy upfront with liver-directed therapy. For the motion, introducing Dr. Kshitij Joshi. Sir is consultant medical oncologist at Mumbai Oncocare, Ville Parle.
I'll play it from there.
Thanks organizers for giving me this opportunity, and yeah, so the topic given to me is a little more difficult for, I think initially I thought, and the opponent against whom I am going to debate is even more difficult. So it's a difficult task, but I consider that this is a learning opportunity for me, and I will just proceed. So the topic is role of systemic treatment upfront with liver-directed therapy in HCC. Okay, for the motion, everyone is aware, TACE and thermal ablation are the initial these therapies which are considered as a local therapies. This is a typical that everyone is aware intermediate stage HCC where the TACE lies and the local ablation is little early. But I just want to comment on one thing, that the intermediate stage HCC is not a single stage. It consists of different styles. So everywhere the response of every therapy like a test is different. We can see here in the green, these all are intermediate stage HCC, but the response rate, especially in multiple more than 7, is less. So why systemic therapy with LDT? LDT leads to hypoxic environment leading to changes in VEGF expression and release, that is typically because of TACE, and it can enhance the immunogenic efficacy for HCC by making changes in tumor microenvironment and immune cell infiltration that happens in thermal ablation as well as TACE. So what are the trials supporting that? So typically 2 trials. The first one is TASTE trial and second is tactics. So there is quite a difference. The TASTE trial does not show that much difference, which can see here. The PFS difference, because both these trials, it was approved initially on the basis of PSFs and not OS. But the TASTE 2 trial, we can see the difference is not significant, but the tactics trial, it is a significant difference, 25%, 25.2 versus 13.5. Is it working? Okay, sorry. So I will operate from here. Okay. So these are all trials. And the last one, the same what we have discussed. And here I can see, just to add to the discussion, what was this trial which leads to the approval of the sorafenib and the usefulness of sorafenib along with the test. The factors, 80 patients, then there is a childproof A was almost 80% were there. And here we can see the definition of progression was the new lesion was not considered as a progressive disease. That's why we got this result of 25.2 versus 13.5. So is that significant? For the numbers, it's significant, but there are many factors here hidden. So this is the tactics trial. So is this a correct tactic to prove that the test with sorafenib is a correct combination? So this is a conclusion of the trial. And one more point for the OS endpoint is that typically in the era of the sequential therapy, OS may not be something that we should consider, but the PFS benefit that we have got. And here it is the meta-analysis and systematic review which shows these results. So let us move to one more local therapy, Yttrium-19 with TKI, and it also shows typically, this is single-centered retrospective that shows the PFS advantage with this combination. So definitely it has a role. Still, local therapy and TKI, it was not enough to prove that this is the treatment of choice. Then now what? The question answer to this is immunotherapy, because what we have discussed, the immunotherapy has given us advantage in a recent metastatic setting. And what are the trials? But so this is a trial that I have found. The efficacy and safety of TASTE combined with sorafenib plus immune checkpoint inhibitor. So this is a triple combination we are talking about. And for the treatment of intermediate and advanced TASTE refractory hepatocellular carcinoma, and this is a retrospective study. And here the study design was there. We can see the ultimate number which was pointed out to be 29 versus 22. And here it is not clearly visible there, but I can read out what were the results. The triple therapy has shown actually the response rate that is 81.82 versus 55.17 in a double therapy. When you combine triple therapy, OS was 16.26 versus 7.3, definitely significant. And so the conclusion of this trial was therapeutic schedule of TASTE plus sorafenib plus immunotherapy demonstrated efficacy and safety in intermediate and advanced TASTE refractory HCC. So definitely immunotherapy is there and we can use it in the future. So what might be our future strategy in intermediate stage HCC? So this might be a future strategy. I just want to stress. Here's, we can see if it is a TASTE suitable, we can go ahead with the test plus or minus TKI. Because of this evidence I have suggested, I am talking pro take TKI, so I will tell you go along with TKI, and then there is a chance. So in a intermediate state HCC, even it is means we are, although in the cure is very difficult, we are aiming at cure in the future. So here with this TASTE plus TKI, this is cancer free, drug free. That is our aim. Suppose it is a test unsuitable, then there is a trial, lenvatinib test, LEN test trial, which use as a NACT, reduce it, use test, then cancer free, drug free. And then suppose it is not test suitable, then there is one more option to use NACT like atezolizumab, bevacizumab, CR, PR, if tumor shrinkage that we can observe, then we can go ahead with the local therapy like TESS and RFA, and the conversion rate here, it is 20 to 30, which is quite significant. So here I think we are moving towards. So what are upcoming studies? So these all are upcoming studies with various combination of TKIs, immunotherapies, and we are moving towards it, and we are hoping that definitely this is going to help us in the future to decide a treatment of HCC. So future of multimodality treatment is for HCC, it is the power of unity. This is the power of unity, means not just a good practice that we are doing, but it is the power of unity of all radiation oncologists, medical oncologists and surgical oncologists coming together, and this will give us the result. Thank you very much.
I invite Dr. Muzammil Sheikh as a debater against the motion. Dr. Sheikh is a consultant medical oncologist at Nanavati Max Super Specialty Hospital.
Thank you, MOC and Ganesh Ashish. So my earlier colleague and debater has set the tone. It is very difficult in a medical oncology dominated meeting to undo the things what they have been doing for last 3 hours. Talk against the motion of giving immuno or targeted therapies along with a local therapy. We'll try to just put forward few points, and that can be very simply put. In fact, my previous debater actually accepted it, that there is definitely paucity of data as far as real evidence-based treatment is concerned for this disease. Whether we should, I will take my specs. Sorry. There is definitely paucity of data, and when it comes to this particular debate, I think this debate was not properly defined. I want to say that because talking about liver-directed therapy plus TKI in SCC is a huge topic. You should possibly divide it into 2 parts. One is intermediate stage, BCLC, and one is advanced stage, because these two are different disease biologies altogether. A local small volume SCC can do well for years, not months, whereas a multinodular, multicentric disease may not do well whatever we do. So these are different biologies. So possibly our role, and that what we can take as a take-home message when we end this debate, is that possibly this should be seen separately, where maybe, my previous speaker also is right. But, he was too much overwhelmed with the topic. So what we see depends mainly on what we look for. So he was looking for an evidence to say that this combination actually works. But the matter of fact is that there is no evidence. If you talk about true intermediate risk, but I will appreciate for him saying that intermediate risk SCC is not a single disease. It's a spectrum. There are multiple types in an intermediate risk, which possibly we still don't know. We need to define that, wherein we'll be able to bifurcate the real role of adding immunotherapy or a TKI along with a liver-directed therapy. But when we take as the basket diagnosis of intermediate risk, there is only one answer to it. Standard of care of unresectable intermediate risk of SCC is loco-regional therapy, period. There is no TKI, PKI, there is no immunotherapy, whatever we may say. There is no data as of now. When we extrapolate this data, we make intermediate complex ones with multiple lesions, or we are talking about advanced SCC. That is what most of the trials had. They had a mixed bag of both the patients, and more so were the advanced cases where these therapies have proven some benefit. So you take any practical guidelines right from Europe to America, you will see that is very, very uniform. That the only option that we want to offer a patient today of intermediate risk is only loco-regional therapy, and this is not evidence. This is not without evidence. People tried this in multiple various trials to find out. This is what have been highlighted throughout the meeting today, that intermediate risk, none of the guidelines is saying anything other than chemoembolization. There is a separate division here. If there is an advanced cancer, they talk about systemic therapy. If there is an intermediate risk, they talk clearly about only loco-regional therapy. They are not adding anything here in any of the guidelines, and there is a reason for it. So this again we have gone through many times. You take any other guideline, you take European guideline. This is a guideline from, we follow two in India, either ESMO or ESCO, or the American guideline. Both the guidelines are concordant upon a local therapy in a patient of intermediate risk SCC. These are few more data, recent ones, And this has been, they tried to do many trials. Few have been alluded by Kshitij, like TACE and tactics too. All of them were negative, except tactics. And that is what he tried to impress upon. Out of the 6 trials, he picked up one which showed positive result. All 5 were grossly negative results. And these are the few trials. I will not bore you because this has been covered. All these were failure except tactics. This is a negative trial, and this is the tactics trial which we are talking about. Problem with this trial is what, this was a manipulated trial, I feel. Because in this trial, what they have taken as a progression, till now all 5 trials was the standard RECIST criteria, and then they realized that we are failing miserably. So they changed the criteria. Instead of RECIST, they changed the criteria of seeing a lesion. They made it RECIL, which means that if patient is having even a new lesion in the liver, new onset lesion, they are saying it's not progress, aankh band karenge. Because it should just non-traceable. If TACE is not possible, that is taken as a progression. A new lesion was not taken as progression. And if you see the outcome of this trial, it looks like a joke to me. TACE plus sorafenib, 25 months of first line survival. So this is a little bit of a rigged one because none can replicate this ever. This kind of a first line survival, 25.5 months of a PFS data is a little bit more magical for me. Possibly it was depending upon how you're doing your scans and what you're looking in your scans as a criteria for progression. So this trial is there for us to give it, but with a pinch of salt. And now we have this recent, ASCO GI, which was 2021, that it clearly said that when we try to look at the hard endpoint in any solid tumors, overall survival, it failed miserably. But then any solid tumor today, whether it's breast, ovary, or SCC, the counter argument always is there that now since we are in an era where there are multiple treatment options, OS should not be the endpoint or a benchmark for comparing any trial because it is really affected by the subsequent lines of therapy, which partly is true. But to a patient, when they know that if I'm spending through my nose, I'm going to spend 10 lakh rupees, am I living one day more or no? That answer still is not there. No, he's not living one day more. Then we try to justify that even PFS is not a bad bet. You have got a PFS, so you were without any progression on a continuous therapy, which was sucking your money and energy, and you have not got a single day of life. So these are all endpoints which I think we don't know, what justice we are doing when we design a trial. When we want to really help a patient, is PFS the criteria or OS the criteria in metastatic solid tumors? The debate goes on. Most of the medical oncology community has accepted that PFS also is a decent benchmark because it gives some quality of life without disease progression. But there are also counter arguments to that when it comes to finance, and in a finance constrained country like us. We will not open that debate here. But for SCC, intermediate grade, only loco-regional therapy, no added benefit of any additional systemic therapy. These are the same trials which Kshitij has elucidated. Nothing new in this. So what is the evidence? No major guidelines says, because it is only useful in certain situations like say TACE, refractoriness or failure, which I will not be covering today, or unsuitability for TACE. So these are few clinical situations where you may try to do a little bit more than the usual stuff. But I think with the shortage of time, we will not go into details and trials of this. These are the guidelines very clearly. Again, this is a 2022 recent, as we talk this year. Still with so much of effort and all, in 2022, most of the guidelines are saying that in intermediate SCC, only loco-regional therapy should be given. Again, I will impress upon that it is not a single disease. Maybe in coming few years, we will have a differentiation in intermediate risk. Okay, and all these trials on which we are talking about were all a mixed bag of advanced disease. Macrovascular invasions, multinodular lesions, and most of the patients were falling into advanced diseases actually. And they try to extrapolate the data. And as we go ahead, when we talk about certain trials, this is what he touched upon, Kshitij, launch trial. So this is interesting trial. This is again, it's a advanced stage. This trial was purely advanced stage. But here they have given a combination of TACE with lenvatinib. So this was a positive trial. You see the curve separating beautifully, but this is an advanced stage. There are different flaws in this trial. This we cannot extrapolate to say that all patients of intermediate risk or localized SCC should be getting a TACE plus some systemic therapy. No. So this is an advanced particular stage. And this is the new data which is going to come up, the triplet regimen which was talked about, immunochemo TACE with sorafenib with immunotherapy. This looks quite promising to us. Again, very small numbers, but looks promising because there is a biological hypothesis. By giving a VEGF inhibitor before, you're normalizing the blood flow, then you give TACE, then you cause more antigenic disruption because of the hypoxia-inducible factors. More and more antigens are in the circulation. Now you give immune therapy. These patients are going to do well. Such a wonderful biological hypothesis. In future, I'm very sure these trials are going to be positive. So I will end my debate saying that very clearly, pure intermediate SCC, only local regional therapy, no added benefit of giving toxicity. If the patient is an advanced cancer, advanced SCC, I think you should utilize more and more of TACE. Your backbone will remain systemic therapy. It can be a atezo-bev with a TACE. There is trial going on and it looks like positive. There is a trial of lenvatinib with TACE and immuno with TACE. So all those is going on and those are positive trials. So backbone remains systemic therapy. You can add TACE in between once or twice to prolong the disease course. I rest my argument here. Thank you.
I will invite Dr. Vashisht Maniyar for his remarks on this debate.
Thank you, Dr. Kshitij and Dr. Muzammil, for very succinctly putting the facts, and the fact that both of them seem to agree and disagree on similar points tells us that while all of us want newer treatment options to succeed, what Kshitij mentions is more aspirational, and what Dr. Muzammil mentions is the stark reality of where we stand today. But technically, if you have these, so there is no data where up to 7, in B1 lesion, you can probably contemplate using a combination of therapy. But in strictly intermediate risk, you would want to limit to local therapy and reserve your systemic therapy for progression. While if you have high risk factors, B2 or C, it's a no-brainer that you anyways are dealing with an extremely bad biology and whatever works. So thank you for this fantastic session, and the debate will remain open because a lot of questions will be answered in the coming years with this data being materialized in a more definitive way. Thank you.
I thank all the faculty for making it for this program despite their busy schedules. With this, we call it a day, and we all can help yourselves at the drinks and dinner counter. Thank you.